Ma'am, we are live. We can start now, ma'am.
A very good evening to everyone who has joined us today, and warm welcome to our session. This is a new initiative that we are attempting. So let me just start off the session. Are you able to see my screen?
Yes, ma'am.
Okay, great.
Yes.
All right. So we'll start off with the first session, which is with regards to controversies in thyroid malignancy. And to chair that session, we have none other than Dr. Sarita Bajaj, who really needs no introduction to this August gathering here. I am having some trouble with my PPT. Is my PPT visible?
Not yet.
No, Belinda, it was there and it went back.
Okay, all right.
Disappeared now.
Just give me a minute. Let me share it again. Yes.
Yeah, it's back. I think it will continue now.
All right. So, so we have none other than Dr. Sarita Bajaj to chair our first session, and ma'am has also graciously agreed to introduce the concept that we are starting off today. So ma'am really does not require any introduction to any of the endocrinologists in India. We are all very, very familiar with ma'am, and we are really privileged and honored to have here ma'am here today to inaugurate this session, because like we were discussing earlier, she is the ideal person to be introducing the concept and, you know, starting off this new session of controversies in endocrinology. So what it is all about, ma'am will be telling you in a minute or so. Ma'am has had many illustrious positions over the last many years. She's been the president of RSSDI, president of Surface Foundation, president of Endocrine Society of India. She was the editor-in-chief of the ESI Manual of Endocrinology, both the first and second edition. Ma'am has received multiple lifetime achievement awards over her career, and she has more than 200 publications. Her areas of interest are endocrine education, thyroidology, and obesity. And ma'am, without further ado, let me hand over the session to you to take it forward from here.
Thank you. Thank you, Belinda. Thank you for those very, very kind words, and of course for the honor of inviting me for this very unique standalone meeting, which I think is being organized by the women, of the women, but I hope it is not only for women. I trust this is for mankind or humankind. I think that mankind word wasn't right. It should be humankind, isn't it? So anyway, so I think this is a very, very welcome forum, and I think it's the first one that we are starting off with, ESI Symposium on Controversies in Endocrinology. As to why we are doing this, it's a new initiative which is being started under the banner of the Endocrine Society of India. And the idea is to provide a mentor-mentee framework for younger women endocrinologists. I'm really, really proud of the young women endocrinologists. They are our real stars. And they're really, really shining bright. And throughout, like the webinars that are going on, they've been doing exceedingly well. So I'm really, really proud of them. And the idea is to provide a platform to develop collaborations and, of course, camaraderie, friendship. And the whole idea is to share knowledge that we obtain while we are reading, our clinical experience and research experience as well. So the idea is to discuss common dilemmas in clinical practice for which there are controversies. So that is why we are calling it Controversies in Endocrinology. And the whole idea is to utilize this platform to create awareness on, of course, women-focused specific health concerns in endocrinology, and to be able to provide access to all women, even from the remotest corner of the country, and maybe the globe as well, and to use this platform to acknowledge and give tribute to all the eminent women in the field of Indian endocrinology. And we are standing on their shoulders today. So with that brief introduction as to why we are focusing on women, I would like to invite the first speaker, and the topic is, of course, the moderator for the session with me is Belinda, and of course she's faculty in St. George Medical College, Bengaluru. The topic is controversies in thyroid malignancy. The first speaker on controversies in management of differentiated thyroid carcinoma is Dr. Pramila Kalra. I beg your pardon. Professor and Head of Endocrinology at Ramaiah Medical College and Hospital, Bengaluru. She has her education and training undergrad from KGMC Lucknow, MD Medicine, both undergrad and postgrad from KGMU, and DM in Endocrinology from SGPGI. And her professional interests are thyroid disorders and gender dysphoria. She has almost 70 publications in national and international journals and 23 chapters in various books. And she's member of very prestigious societies, and she's graduated with honors in her MBBS, and she has received several prizes as well as gold medals. And it's a very proud moment. I love hearing her talk. So it's a pleasure to introduce the first speaker to you. Over to you, Pramila.
Thanks, ma'am. Thanks, ma'am, for the kind introduction. And thanks, Dr. Belinda, also for inviting me for this talk. And I think it's a very nice idea to talk about these topics, because these are the things which are hardly discussed in most of the forums. Because whenever we talk about any controversy, we just try to say, okay, we'll read and we'll decide and we'll talk about it. But this topic is only controversy, so we have to discuss the controversies only. So I think it's a very nice idea. And my topic is like controversies in the management of differentiated thyroid cancer. So when Dr. Belinda gave me this topic, initially I thought, yeah, we have so many controversies. But when I started preparing for the talk, then I realized that there are many more which we haven't even thought of many a times. Now, if we see that, we know that the thyroid cancer incidence is unfortunately increasing over a period of time, and there are multi reasons for that. And we know that about 85% of all thyroid cancers are papillary thyroid cancers, while follicular and Hürthle cell cancers make about 5% of all the thyroid cancers. And it's the 5th most common cancer in women. Now, when we talk about controversies, we know that we have multiple things which we need to talk about. But the first thing which we always talk about is definition of the low risk versus the high risk, or what is the low risk and how do we decide that? Now, different guidelines have put various ways to define a low risk versus a high risk. Like the ATA, I'll talk about that in the next slide, but the American Joint Commission for Cancer has labeled it like that, and they have put only the tumor, the staging, and that is N and M, that is the conventional what we do to decide about the survival or the low risk. And they classify like this, like less than 55 years in stage 1, any M0, but less than 2 centimeters.
Yeah,
yeah.
Voice is cracking.
Okay, now is it okay?
Yeah, it's fine now.
Yeah, so T more than 2 centimeters, but less than 4 centimeters with N0, and more than 55 years in stage 2. So tumor more than 4 centimeters or any tumor size which is with extrathyroidal extension is the one which they have classified into the high risk. But if you see the ATA classification, they have discussed more on the metastases, and also they have taken some other criteria like no local or distant metastases. All macroscopic tumor has been resected. So basically they are talking more about recurrence. So they are deciding the low risk based on the recurrence. And the not have aggressive histology after the surgery. They have tried to see the tall cell and all those which have aggressive histology outside the thyroid bed on the first post-op treatment whole body radioiodine scan. No vascular invasion. So this is how they have tried to see the classification, or they have tried to label it. this is the initial controversies, like this is the classification. But when we come to the list of controversies, these are the list of controversies. One is the surgery versus the active surveillance, the extent of surgery, the molecular markers, the prophylactic central lymph node dissection, whether it needs to be done for all or not, choosing the surgeon, the radioiodine ablation, and the dose of levothyroxine post-op. So coming to the first controversy, that is the surgery versus the active surveillance for the papillary cells are there, which support if these patients can be followed up with serial ultrasound with every 6 to 12 months. And they have found that majority had little increase in, if any, in the disease progression. So this is the first thing, which is still a controversial topic, because some studies initially said that no, we have to go for surgery, but now more and more studies have come up which have advocated active surveillance approach and a follow-up USG every 6 to 12 months to see if there is any progression of the disease. Whether to go for lobectomy, we know that if the tumor size is small, like less than 1 centimeter, we have the option of that. The pros of the lobectomy is there is excellent survival as the total thyroidectomy for tumor size less than 1 centimeters. And there is, the more than 1 centimeter, between 1 to 4 centimeters, what we are talking about, lower risk of surgical complications, and may avoid the need for full replacement. So what they have found that the patients had tumor size more than 1 centimeter, but less than 4 centimeter, they have found that lobectomy gave an excellent survival, and they did not find any increased survival with total thyroidectomy over and above the lobectomy patients. That is why the guidelines got changed. And now they are advocating more and more lobectomies for these patients. And also to add to that, because if lobectomy is done, the risk of the complications is much lesser. And they also say that unnecessarily the patient is put on full replacement, which can be avoided if the patient undergoes a lobectomy. But this is there for the tumor size more than 1 centimeter, but less than 4 centimeter. But the cons are also there, which is the issue of discussion, because some studies have shown that the recurrence rate might be slightly higher. But still, if you see the guidelines now, they are advocating more in terms of lobectomy for tumor sizes 1 to 4 centimeters. So while surgical alternatives range from lobectomy to subtotal thyroidectomy, the tumors which are not exceeding 4 cm, with or without lymph node dissection for some advanced tumors, also people are discussing about active surveillance in this group of patients, but those studies are very small. Active surveillance is mostly advocated for less than 1 centimeter. 1 to 4 active surveillance without a surgical intervention is sometimes the norm in some patients where you have done the molecular genetic markers and you have found that it is a very low risk PTC. Those patients can be discussed this option of an active surveillance. But you have to understand that in a country like India, most of the times we won't go for this last option in such patients if it's 1 to 4. At the moment, it's the discussion of lobectomy versus subtotal thyroidectomy versus the total thyroidectomy. So this all has to be discussed with the patient, because a lot of times the patients don't come back for follow-up, and then we may have problems with the follow-up and recurrence rate, which may be different for our set of population. So if you see, that is why the ATA has over a period of time changed its guidelines. Like they are now talking about that we can go for surveillance with tumors which are less than 1 centimeter. We can talk about lobectomies. We should not go for prophylactic lymph node dissection for all these patients. And even the other guidelines are also recommending that lobectomy can be an option for tumors less than 4 centimeters. But yes, if the tumor size is more than 4 centimeters, more or less there's a consensus in most of the guidelines about the total thyroidectomy. Now, the controversy 3 is the genetics. Now, 2015 ATA guidelines have focused more on alterations which we can see, which can be a predictor of malignancy. And we know that free cell DNA and other methods are being tried to find out these patients and to predict even from the FNAC that whether this nodule could be a higher risk for malignancy versus not. Because now we know that there are options like free cell DNA which can be done from the blood only to check if this lesion has a higher propensity to be malignant versus a patient who has a lower risk of malignancy. So all these things are there, but sometimes these things again may be difficult in our setup, so maybe a little bit difficult to incorporate at the moment. Now coming to the prophylactic central lymph node dissection. So we know that the benefit versus the risk is not immediately discernible, and we know the studies have shown that as many as 31 patients would need to be treated with prophylactic central lymph node dissection to reduce the risk of recurrence in one case. So again, people have tried to say that the extrathyroid extension they have seen in patients also who did not have the prophylactic central lymph node dissection. So again, this is a little bit of a controversial topic where people are advocating that prophylactic central lymph node dissection cannot be extrapolated to low risk differentiated thyroid cancer, but definitely in high risk patients, we have to do it. But still, there is a possibility that patients who don't undergo a prophylactic central lymph node dissection may have a higher rate of extrathyroidal extension, which was seen in around 12.8 to 58.5% of the patients who did not undergo a prophylactic lymph node dissection. Choosing the surgeon. Now, this is a most controversial topic because no specific recommendation exactly is there for the clear threshold. Some of the studies say 30 surgeries in a year, some say 25, and they take the centiles. But they have some have taken 25, some have taken 30 as a high volume. The intermediate, they have tried to say between 4 to 29 and 1 to 3 as the low volume. So after adjusting for the patient demographics and the comorbidities, diagnosis, and hospital characteristics, patients who were treated by so-called low-volume surgeons were actually 51% more likely to incur a complication. And I would say in Indian setup, it is even higher. The patients who go to low-volume surgeons, we do see, unfortunately, a lot of complications post-op. Now, the controversy 6 is the radioiodine, whether to give or not to give, because till now, what the practice was to give radioiodine to all these patients. But now the controversy is there. The data suggests that low or intermediate risk patients, the risk of recurrence or the difference in the likelihood of recurrence with or without radioiodine, if the unstimulated thyroglobulin is 1 to 2, is like difficult to say that it will recur. So if the stimulated thyroglobulin is more than 5, then the radioiodine may be beneficial. But if it is between 1 to 5, then we have to have additional clinical factors which should be used to help determine whether it is needed or not. And if the level is 1, then it is unnecessary. Administration also is a controversy. Some say that we have to use the SPECT CT with the pre-treatment scan. The pros of that are to determine whether the atypical uptake in thyroid cancer versus the physiological or the non-thyroid in origin, identification of regional and distant metastases prior to the radioiodine therapy. But the cons are cost issues and may benefit select patients. So this is again a controversial thing. Now, which isotope use is also a controversy because they say for the pre-treatment scan, we can use either a low-dose I-131 or we can also use a low-dose I-123, which can be associated with less stunning. And now there are studies to show that if I-123 is given, the stunning is less, and actually this could be a preferable option, or some studies have also tried to see it with technetium. The controversy 4 is the recombinant TSH versus the withdrawing of the levothyroxine. We know how difficult it is for patients to live in that 1 month without levothyroxine when they come with so many problems. So now data from RCTs have suggested that recombinant is as effective as withdrawal for the levothyroxine in low-risk DTCs, and the quality of life is compromised to a great extent. And now in India also, we are trying to work more on good quality of life for these patients. And we are trying to work more and more on this. But we know that recombinant TSH is a costly thing, but it is associated with reduced radiation exposure to the body as compared with the withdrawal therapy. This also has been studied. And still, we have to understand that it's a costly therapy, may not be the best scenario for our country at the moment. At the moment, most of the patients, we go ahead with the withdrawal. But yes, in an affordable patient who can go for it, we can talk about these options and give them the options. The controversy 8, the optimal dose. So there are studies which have shown equal efficacy between the low and the high dose radioiodine. Now you can see people have tried to do different types of doses. The dose for remnant ablation to 30 to 100 and 30 millicurie is favored over higher doses in the new thing. If you see, So when to treat, if the radioiodine ablation definitely is not routinely recommended for unifocal papillary thyroid microcarcinoma or the multifocal papillary thyroid microcarcinoma and other low-risk DTCs. However, specific features of the patient that affect the recurrence or the disease follow-up implications and patient preferences should be considered. Recombinant TSS stimulation is an acceptable option to withdrawal, may lead to less radiation exposure and better quality of life. And now they say that 30 millicurie is favored. In some of the studies, they have tried to see over the higher doses. So that is another controversy which is there. And the last controversy is the thyroid hormone replacement. The suppressive therapy, we know that now traditionally when we were doing TM, we were taught that we have to keep it too suppressed and very low. But no, we know that over a period of time, a lot of data came up and they did not find any survival benefit with more intensive TSS suppression in these low-risk cases. So they have liberalized the TSH goals. And now we say that patients with undetectable serum thyroglobulin levels after total thyroidectomy, TSH may be maintained at the lower end of the reference range of 0.5 to 2. Little data on optimal TSH goals post-lobectomy is there at the moment. I tried to review the studies, but they have not reached to a consensus basically. But TSH may be maintained in the mid to lower reference range is what they say, that is 0.5 to 2. That is what they say should be apt for these patients. To summarize, we know that we have now minimal surgery for low-risk patients. They say because it gives a good quality of life, you reduce the risk of complications, don't unnecessarily subject the patient to unnecessary surgeries, and also you can also need not give a lot of levothyroxine to these patients, because if you do minimal surgeries, they may not require much of levothyroxine as well. And radioiodine is not for everyone. So micropapillary carcinomas and all may not require it. Very low risk cases may not require it. And the dose of 30 may be apt. So this is the new thing which is coming up. And we all know that we have got the TSH guidelines relaxed as per the ADA guidelines, and they are less stringent for low risk patients. So these are the newer controversies. The controversies are on. And in endocrinology, we know everything has a controversy. But these are the major controversies I thought I should put in this talk. Thank you.
Thank you. That was excellent, Pramila, and especially bringing out the controversies and making us think that, yes, there are many more which have not been covered. So I think we'll keep that for the discussion. I hope we have some time later on. And please wait for the question and answer session and for the discussion later. So moving on to the next controversy, again in thyroid cancer, is medullary thyroid cancer. And we have with us Dr. Beatrice Ann. Could I have the intro slide, please? I think I just saw it flash and then it disappeared. Yeah, there we are. She is Associate Professor and Head Department of Endocrinology at Nizam's Institute of Medical Sciences, Hyderabad. And she has a gold medal in DM endocrinology, as well as the API gold medal in medicine. And she has several awards, for example, the Best Research Paper Award at RSSTI and the West Bengal chapter. She has authored various articles in international, national journals, and she's actively involved in several research projects. She's also authored a chapter in a very prestigious book. So over to you, Beatrice, for controversies in approach to medullary thyroid cancer.
Thank you, ma'am, for the kind introduction. A very good evening to all of you. So over the next few minutes, I'll be talking about the controversies in approach to MTC. Now, we heard Pramila ma'am talk about the controversies in PTC, which is in fact the most common thyroid carcinoma. So we'll look at medullary thyroid carcinoma, which in fact, it contributes to less than 4% of thyroid malignancies. And there are certain unique features of medullary thyroid carcinoma, which we need to keep in mind when we do approach the patient. And that is that MTC is derived from the parafollicular C cells, and 75% are sporadic. And we do have hereditary cases like associated with MEN2A and MEN2B syndromes, and also the familial MTC. And MTC as such, we know can express hormones. We know it expresses calcitonin, but it can also express calcitonin gene-related peptide and ACTH, which can sometimes lead to Cushing syndrome. And we have biochemical markers like calcitonin, and CEA, which help us with the pre-op and the post-op evaluation of the patient. And we know that there is a RET mutation. So we do have newer therapies like targeted therapies. So we need to keep all of this in mind when we approach a patient with medullary thyroid carcinoma. So with this background, we'll have a look at the controversies in diagnosis and the controversies in management of MTC. So we'll have a look at the controversies in diagnosis. So solitary thyroid nodule is going to be the most common presentation, and most patients, the disease is already metastasized at a diagnosis. So 70% of the patients have clinically detectable cervical lymph node involvement, and 15% have aerodigestive tract compression, and 5 to 10% have distant mets as well. So like any thyroid nodule evaluation, the ultrasound is going to be the first line imaging for patients with suspected MTC. So it has a sensitivity of around 75%, a specificity of 93%, and an overall accuracy of around 80% for picking up MTC. And there are a few features of MTC on ultrasound. That is, they have an irregular shape, they have lack of a peripheral halo, they are hypoechogenic. So all this is similar to the PTC. And calcification is typically macrocalcification in patients with MTC, and they're typically more hypervascular than the PTC. So we were all happy with this sort of a profiling before, but we have this recent study which was published just 3 months ago in the European Journal of Endocrinology, which basically looked at MTCs, around 100 plus MTCs, and they have in fact looked at how the risk stratification scores, that is a TIRAT score that we use to stratify the risk in patients with thyroid nodule. How does it fare in picking up MTC? And this was what was shocking, because neither single nor the association of ultrasound features were specific for MTC. And the 5 main RSS, that is the risk stratification score, currently identified less than 50% of the MTC. And in fact, they do not even suggest performing FNAC in about half of them, which means that we are going to be having delayed diagnosis, and in worst case scenarios, it's going to be delayed diagnosis. So that being said, the second investigation that we undertake for a patient with a thyroid nodule is going to be the FNA. So the sensitivity of FNA is around 50 to 80% in picking up the MTC. But most often it is interpreted as a follicular neoplasm or follicular lesions of undetermined significance on cytology. How do we increase the case finding here? We can do immunohistochemical staining for calcitonin. So the question which arises here is indeterminate FNAC. So Dr. Indra will be talking about indeterminate nodules. So when we do get an indeterminate FNAC, should we go ahead and stain for calcitonin? This is a controversy because we do not know the answer as of now. But on the other hand, there are studies which have looked at serum calcitonin screening pre-op. And what they have found is the diagnosis is established at an earlier stage when we do serum calcitonin screening in a patient with an indeterminate nodule, which happens to be an MTC. And they are more likely to achieve complete remission this way when we pick them up earlier. And they also are found to have prolonged survival. But what we need to really keep in mind is there can be false positive in serum calcitonin. So other conditions which can cause an increase in serum calcitonin, namely renal failure or ectopic calcitonin secretion from other neuroendocrine tumors, hypergastrinemia, or sometimes even heterophile antibodies. So all these need to be ruled out. And some of the guidelines, in fact, state that pentagastrin stimulation test, which is almost phased out now and it is being replaced by the calcium stimulation test, may have to be done to rule out ectopic calcitonin secretion from other neuroendocrine tumors and not from the thyroid origin. So again, this is a controversy here because we do not know when to go ahead with the calcitonin stimulation. So basically, most of the guidelines, in fact, do not recommend a serum calcitonin pre-op evaluation of indeterminate nodule, except the Europeans. The European consensus says that routine measurement of serum calcitonin allows the detection of unsuspected medullary thyroid carcinoma with a frequency of 1 in 200 to 300 thyroid nodules, and it has a better sensitivity than FNAC. And in fact, this routine calcitonin screening improves the outcome. So the Europeans, in fact, they they advocate or serum calcitonin measurement is recommended in the initial diagnostic evaluation of thyroid nodules. So Pramila ma'am was talking about how we have moved away from thyroidectomy for localized disease or less than 1 centimeter carcinoma, where we are moving more towards lobectomy. So the other scenario may be a patient who has undergone lobectomy for a thyroid nodule, and the histopathology springs a surprise. It shows medullary thyroid carcinoma. So what do we do about it? What is the controversy here? So here, do we go ahead with the completion thyroidectomy or not? So this is a consensus, in fact, from the guidelines, that when we have a sporadic MTC, so if the patient does not have any germline RET mutation, no completion thyroidectomy is required. On the other hand, in a patient with sporadic MTC, when there is a germline RET mutation and when the serum post-op serum calcitonin is more than the upper limit of normal, and when we do have imaging evidence of persistent disease, then we go ahead with the completion thyroidectomy. On the other hand, hereditary MTC has to undergo completion thyroidectomy. So the surgical approach is again another controversy. So we know pre-op, somebody who has been diagnosed with a medullary thyroid carcinoma on FNA, total thyroidectomy is the preferred option, because 10% of sporadic and all inherited MTCs have bilateral or multifocal disease. The question here is, what should be the extent of lymph node dissection? So again, the extent of surgery depends on the lymph node positivity. So if there is no ultrasound evidence of cervical lymph node involvement, we go ahead with a total thyroidectomy and a prophylactic bilateral central lymph node dissection. On the other hand, when we have a small intrathyroidal MTC, and if the pre-op calcitonin is less than 20, we go ahead with a total thyroidectomy, but no prophylactic central lymph node dissections. But all these are consensus. We still have controversies regarding this. So the question here is lateral lymph node dissection always necessary? We do not have consensus, even with the American Thyroid Association. And they say we can consider it based on the serum calcitonin levels. When the serum calcitonin is more than 20 picogram per ml, we advocate ipsilateral central plus ipsilateral lateral neck dissection. When the serum calcitonin is more than 200 picogram per ml, then we advocate an ipsilateral central plus ipsilateral lateral and a contralateral lateral neck dissections. Now there are proponents and opponents for this prophylactic lateral neck dissection. So those who advocate the prophylactic lateral neck dissection argue that patients have better biochemical cure when we subject them to prophylactic lateral neck dissection. They have a better survival rate, 98% 10-year survival rate, and the recurrence rate is low as well. It's only around 3 to 4%. On the other hand, those opponents of the prophylactic lateral neck dissection state that long-term survival is no less in those with incomplete biochemical response. And the most important point here, additional morbidity can be there, especially if not done by high volume experienced surgeons. So the next question, when we have the biopsy, when we have done the completion thyroidectomy, how do we go further with the treatment? So what about the sporadic MTCs? Is somatic mutation assessment required even if they do not have a germline RET mutation? So we have a couple of studies here which say that the presence of a somatic RET mutation, that is mutation in the tumor cells, they're associated with a worse outcome in the MTC patients, and they do have poorer survival rates, and they do have more lymph node metastasis at diagnosis, which itself is a known bad prognostic factor. On the other hand, we also have studies stating the reverse, that somatic mutations in the RET proto-oncogene are seen commonly in patients with sporadic medullary thyroid carcinoma, and they do not, in fact, correlate with any of the clinical characteristics. So this is a controversy here. But what is the consensus? That somatic mutation analysis may not be required as part of routine care, but there is an exception here when we do have progressive metastatic disease which warrants systemic therapy with a specific RET inhibitor, then yes, we need to look for somatic RET mutation. And what about the immediate post-operative management? This I would not say is a controversy, but it is a caveat in the management of MTC. That is, it is going to be different than PTC. So we start levothyroxine therapy immediately after surgery, and our goal will be to restore and maintain a euthyroid state. The CEF cells are not responsive to TSH, so we do not go in for a suppressive therapy. And there is no role of adjuvant radioiodine because the C cells do not concentrate radioiodine. So what about the prognostic markers? We know that MTC is associated with an increase in the calcitonin and the CEA. So the calcitonin doubling time is associated, is a predictor of survival, whereas the CEA doubling time is a predictor of prognosis. So there are other newer markers which have been studied in the last few years. So CA19-9, which is commonly available, procalcitonin, which is a peptide precursor of calcitonin, and it is a more stable peptide, and it has a more predictable half-life, and the inter-assay variability is lesser in procalcitonin. But the studies which have looked at procalcitonin have all been done in patients in the OPD basis after ruling out systemic infections and inflammation. So the other possibility is looking at the circulating cell-free microRNAs, which are again gaining interest as prognostic markers. So the CA19-9, like I was telling, this is especially seen in patients with metastasis. So based on the results of this particular study, they concluded that negative staining of MTC for CA19-9 may be associated with a decreased metastatic potential, so more of a rule-out test. So when do we do the calcitonin and CEA? Again, a controversy here. So ideally or generally, the guidelines say around 3 months. But we need to remember that the length of time to calcitonin normalization is proportional to the nodal burden of disease. So somebody has 1 to 5 positive nodes, the days to normalization may be as less as 5 days, compared to somebody who has more than 10 nodes, where the normalization may require even 57 days. So we need to time our testing accordingly. And we do have newer therapies, the targeted therapies like cabozantinib and vandetanib, which are FDA approved molecules for treatment of MTC. So studies have shown that there is an increase in progression-free survival with both drugs. But the effect of these drugs on the survival of MTC patients remains unknown till now. So, and even here, we do have some caveats. That is, cabozantinib, it works well with codon 634 and M918T mutations, whereas vandetanib works well with M918T mutations. And there are certain mutations which may in fact cause resistance to these drugs. So the question here, the controversy here is, should we do a tumor mutational profile before going ahead with these drugs? Because we know that these drugs have their own share of toxicity as well. So these are newer drugs, that is specific RET kinase inhibitors, which have been very recently approved in 2020 by US FDA. And these are for the RET mutant MTCs, that is selpercatinib and pralsetinib. So the other drugs, levantinib and sunitinib, are also being used, but not yet approved for MTC as such. And adjuvant therapy like external beam radiotherapy, so we still not know, or the controversy exists, which patients benefit from this, because there is a selection bias in almost all the studies, because radiotherapy in all these studies have been reserved for more aggressive disease. Nevertheless, the ATA recommends that adjuvant EBRT to the neck and mediastinum should be given for patients at high risk for local recurrence. So those with the residual disease or extrathyroidal extension, or with extensive lymph node metastasis, or those who have a risk of airway obstruction. So this is again something which is gaining interest in the last few years, the role of peptide receptor radionuclide therapy. Again, we do not know the patient profile, which wherein they may be helpful, and further studies are required for this. And PRRT with somatostatin analogs, like which are radio labeled with yttrium-90 or lutetium-177 have been tried, and there's almost 60% disease control. So these may be considered in selected patients with advanced, progressive, or metastatic MTC in the context of a clinical trial. But all these still need to be reviewed extensively. Further studies have to be done so that they can be incorporated into the guidelines. And the guidelines, especially the ATA, has been published around 5 years ago, and there have been many studies after that. And to conclude, multiple recent updates are available in the management and diagnosis of MTC. We have differences in opinion in surgical management, targeted therapies, and the knowledge regarding this unique sort of thyroid carcinoma is still evolving. And hopefully over the next few years, we'll have enough evidence in our hand to put an end to these controversies. So thank you all for patient listening, and thank you ESI for the opportunity.
Good, excellent, Beatrice. So now we have more controversies to tackle, and please be around for the question answers after the third talk in this session, which is by Dr. Indira Maisna. It will be controversies around indeterminate thyroid nodule. Indira?
Yes, ma'am.
Yeah, she's from Kolkata. She's a senior consultant endocrinologist at RG Kar Medical College. Kolkata, Sharnock Hospital, and Bellevue Clinic, RSV Hospital. And she has 17 years of clinical and academic experience with over 50 publications. Over to you, Indira.
Good evening. Thank you, ma'am, for your kind introduction. Thank you, Endocrine Society of India, and my friends, Dr. Shaila, Dr. Gagan, Dr. Belinda, and Vaishali, ma'am, for giving me this opportunity to share my thoughts on controversies around the indeterminate thyroid nodules. So the prevalence of thyroid nodule is increased, already discussed. So the indeterminate thyroid nodules account for around 25% of the FNA specimen, and the chance of malignancy can be as low as 6% to as high as 75%. And indeterminate nodule management is therefore a gray area, and hence the controversy. So we are aware of the updated Batista classification of 2017. So the lesions which are category 3 and 4, that is the follicular lesion or atypia of unknown undetermined significance and the follicular neoplasm, are considered the indeterminate nodules. So why the controversies around this indeterminate nodule? So if we try to analyze it, the indeterminate nodule encompasses a broad criteria in the sense that not all subcategories have similar rates of malignancy or similar treatment modality. And also the next step to be taken after the diagnosis of an indeterminate nodules have their advantages and disadvantages, which I shall discuss. And let's say an indeterminate nodule has undergone a surgery, and then we find the HPE report. Does it always make the picture clearer or does it not? So how do we have a reasonable way forward? So if you look at the indeterminate nodules category, like I have said, that we have this Batista 3 and 4, which consists of atypias, which could be mild nuclear atypia, or it could be an architectural atypia, oncocytic atypia, or it could be just that the specimen was compromised due to poor fixation or obscuring blood. The chances of malignancy in these groups is around 10 to 30%. But in a follicular neoplasm, the chances of malignancy is 25 to 40%. We need to remember that not all nodules with the same diagnostic category have the same risk of malignancy. For example, an aspirate with a clotting artifact creating a tri-dimensional group does not have the same malignancy risk as a nodule with mild nuclear atypia, which is suggestive of a papillary thyroid carcinoma, but inadequate to make a definite diagnosis at that point in time. But these two scenarios are legitimately classified as Batista 3. Again, the next step is when we encounter an indeterminate thyroid nodule, the options are a repeat USG, a repeat FNAC, sometimes a molecular panel, and sometimes also directly for surgery. So what is the advantages of a repeat USG or a reassessment of the USG? We can take a second opinion, good, from another expert. Also, there are automated second opinions that are developed, which are the computer-aided diagnostic system, maybe a specific training by consensus, which is undergoing in different parts of the globe, would actually help in the joint evaluation of the images. The repeat USG would also help identify the nodule growth and the change in character. And the American Thyroid Association and the AACE have also said that if available, elastography can be used so as to further refine the findings because the malignant lesions are stiff and hard. But we need to remember that none of the sonographic features, when taken in isolation, are high enough to be, are sensitive or specific enough to be clinically relevant, because this depends on many factors like the imaging acquisition or the operator settings, etc. And the ultrasound elastography also has limitations because, let's say, there are calcifications or cystic components in the nodules, then the operator expertise is important. And in conditions like Hashimoto's thyroiditis and acromegaly, it may not be reliable. So the next other option is a repeat FNAC. We agree that there are some inter-observer disagreement among all cytology specimens. But this observer disagreement is much, much higher in the indeterminate nodules compared to benign or malignant nodules. And therefore, and cytological reassessment of a second FNA provides a definitive diagnosis in only 40% of the class 1 and 3 nodules. So is a repeat FNAC always better or always reliable? So let's imagine a case scenario where there was a benign reading in the first, or where there was an indeterminate finding, and in the second one there is a benign reading. So we may have the false reassurance of a benignity despite the presence of a cancer that was missed both times. And let's say if the second cytological specimen is still indeterminate, so the next step is typically a diagnostic lobectomy. But if it turns out to be malignant, then you go in for a completion thyroidectomy. In that case, there is added risk and cost. Whereas if it turns out to be benign, then you have undergone something, an excessive procedure for something that was benign. So again, second opinion and group consensus could help improve the concordance rate. So these are the recommendations by the different authoritative bodies where they have suggested surgery or either a lobectomy or a total thyroidectomy based on the different circumstances, and molecular study where available. Now coming to the molecular testing. Molecular testing, Dr. Pramila Kalra has just introduced it, but to elaborate more on it, molecular testing is a diagnosis of thyroid diagnosis of thyroid cancer may assist in the appropriate management for the indeterminate group. So the molecular marker panels may be divided into three major types. There are the mutational analysis, where the advanced ones like the Thyroseq V3 test 112 mutations, the mRNA classifier system, and the combined microRNA and mutational analysis. So in the US, let's say the cost per nodule of this molecular analysis is around $5,000. So how reliable are they? We will come to it. So before that, the positive predictive value and the negative predictive value. So if the test has a high negative predictive value, it rules out the disease and therefore helps avoid the surgery. But if the test has a high positive predictive value, it means that the suspicious nodule has a high chance of malignancy and needed surgery is given to those who require it. And the developers of these products claim that they have a high sensitivity and enough specificity to function as rule-in and rule-out tests. But are they really the panacea to all controversies? So if we look, the predictive, if we analyze further, we see that the predictive value are much different in the real life. And most often the mutation recognizes a RAS, which may not be a true marker of malignancy in a thyroid nodule. I'll come to it. Not all mutations have similar prognosis, but are grouped together. And again, it gives a positive screen for both thyroid cancer and the new entity, the NIFT-P, which is no longer considered malignant. And also it is important that molecular screens need dedicated and correct specimen collection. So was that done? And do they alter the treatment decisions for the better? Let's see, and the cost effectiveness. So the predictive value is much lower in the real life, as has been shown in many studies. And many times this oncocytic atypia have given a false positive rate, resulting in overtreatment in some people with just, let's say, a little bit of Hurtle cells changes. Again, this is very important. The most common mutation identified may not be the true marker of malignancy in a thyroid nodule. So RAS is one that is most commonly recognized, but RAS mutations are oncogenic drivers in the colon, lung, and pancreas. The role in thyroid malignancy is less well defined in the sense that the positive predictive value of a RAS mutation is only 7 to 25%. And also they are found in benign thyroid nodules. And even if they are found in in malignant thyroid nodules, those nodules tend to be have a quite indolent behavior, which may respond to, let's say, a follow-up or just a lobectomy. Again, not all mutations carry a similar prognosis. Somebody with a BRAF V600E with a TART mutation in the promoter region of TART would have a worse prognosis than a RAS mutation, but then they are classified as positive or negative. Again, NIFT is a non-invasive follicular thyroid neoplasm with papillary-like nuclear features, which was a new category created, almost like the follicular variant of papillary thyroid carcinoma, but without vascular and capsular invasion. So it is now considered not malignant, but not benign either. And when these molecular tests were developed, they identified the NIFT-TP as actually malignant ones, and therefore the molecular panel would test it as positive. And once the diagnosis of NIFT is made, it's agreed that NIFT is a surgical diagnosis, to be diagnosed surgically. A lobectomy is sufficient, but when the screen is positive for a malignancy, somebody might go into a total thyroidectomy, resulting in greater or excess of treatment. Again, molecular screens require proper correction of specimen. So are they done like that? For example, the dedicated needle pass should be there, collection of all the residual material, and even the recovery of cells from the routinely prepared cytology slides. And do they really impact treatment decisions? So again, there are controversial reports. While some shows that there is an improvement in the treatment in the sense that you select the right person for surgery or select the right person who would not undergo surgery. In this paper, it was found that when there is a molecular testing was used to define the surgical choice and the routine clinical algorithm of the institution, the change in the strategy was 10% only. And in fact, 6 out of these 9, that is 67% patients, the molecular testing driven strategy was incorrect and led to overtreatment. Again, other criticism for the molecular testing are sometimes they are done even in patient who is already diagnosed to have a thyroid malignancy. Let's say a Batista 5, it is absolutely useless in those because the molecular panel are to be used in indeterminate nodules. Again, often studies that have shown the positive predictive view, they actually, the histopathologists were not blinded with the, let's say, the molecular panel results, and as a result of which this could have actually affected the reporting of the HPE. Again, there is lack of validation studies, and the availability and affordability are issues. Cost calculations vary. Now, another one, cell-free DNA. So in malignancies, circulating cell-free DNAs represent short fragments of DNA released from the tumors that may contain tumor-specific somatic mutations. They're present in the plasma and other body fluid, and the quantity of the cell-free DNA in the circulation varies according to the nature of the neoplasm. So this was a recently published paper in the JCEM, which actually came back out from our country from IPGMR Kolkata, where actually they tried to find out the levels of the cell-free DNA in those with the Batista 5 and 6. And again, in the Batista 2, that is the benign category, they predicted the cutoff for this one for malignancy, where the cutoff was 67.9 nanogram per ml, and they used it to identify the indeterminate nodules that had a high risk of malignancy. And they said in this paper that they were able to identify malignant lesions with a sensitivity of 100% and a specificity of 92.3%. The next important question is, does the availability of a histopathological report in an intermediate nodule always make the picture clear? Again, we agree that there are borderline differences in HPE reports, especially in the borderline lesions, and most frequent malignancy in an indeterminate cytology comes out to be a follicular variant of papillary thyroid carcinoma. Again, these lesions may be classified as either molecular adenomas with atypia, benign, or a follicular variant of papillary thyroid carcinoma, NIFT-P, or malignant, depending on the pathologist's interpretation. So what is the balanced way forward? We need a multimodality approach. We are not just going to look at the UST and FNSC. Definitely they are important, but the history is important. The history of radiation, history of a family history of a thyroid cancer, clinical risk, is the nodule fixed? Because these are not taken into consideration at the FNSC. So is it fixed? Is it enlarging? Is fixity of the nodules, the physical examination, all are important in identifying whether this particular nodule with an intermediate cytology should undergo a surgery or a repeat UST or a repeat FMA. Again, it is important to standardize the reporting and the interpretation of sonographic findings, maybe the development of clinical risk assessment tools or algorithm for that institute would help. Again, a thyroid multidisciplinary team. Again, it is taken for granted when I presented this paper that in somebody where the TSH was subnormal, definitely a scintigraphy was done. So if that has not been done, it should be done. And because if there is an uptake in the scintigraphy, there is a 100% chance that it is not malignant. In fact, certain authors say that even if the TSH is normal but less than 1, still a scintigraphy would be done because a toxic nodule that may not be too, which is not too toxic, let's say, may not suppress the TSH to subnormal ranges. So scintigraphy in a TSH less than subnormal should definitely be done before going to all these approaches. Again, proper selection of FNA. I think if most of the time we select the proper nodules, that is the thyroids, let's say 4, 5, 6, if we select the proper nodules for FNAC, then there is a little place for doubt, even if, let's say, it's an indeterminate nodule. So I just saw a patient in my OPD today who had a thyroid score of 4, but the first FNAC came out to be just a colloid goiter. Because it was not matching with the thyroid score, I repeated the FNAC and it came out to be a papillary carcinoma or thyroid. So in other words, taking all the information we have together is important to come to a decision, and molecular markers test results have show promises, but also limitations. So to conclude, management of indeterminate nodule is a tailored approach rather than a one-size-fits-all, a multi-modality and a multidisciplinary approach where there should be standardized reporting system for USG and cytology, and the prudent use of molecular markers where available. At every step, the patient should be made an active member in the decision-making process, outlining the advantages, the limitations, benefits, and the risk. And also, which means for health professionals, this means working with some degree of uncertainty, clinical uncertainty, but not jumping to a battery of tests or investigations. Thank you so much for your patient hearing.
Thank you, Indra. Again, that was wonderful. So now we'll move on to the question answers. The first question that we have in the chat box. Yeah, how to follow up patients of micropapillary CA who have undergone lobectomy and have not been subjected to radioactive iodine ablation.
Yeah.
Yes. There you are.
So, yeah. So the micropapillary CA, if they in case they had not on active surveillance and then undergone lobectomy and we have to follow them up, or even if they are under active surveillance, ultrasound is the basic modality for follow-up. But the ultrasound also, along with that, we have to remember that a patient who has undergone lobectomy and had a micropapillary CA that is less than like 1 centimeter, then most of the time the recurrences are seen in the other lobe. And or in the cervical lymph nodes, we'll see a METS. So these patients need to be definitely followed up. If we are finding anything which is suggesting a higher risk, like if the patient has a change in voice or some lymph node which is showing a higher risk on the ultrasound, that we have to do a FNA of that. Also, we have to understand that there are studies, there are lots of data on the thyroglobulin level, though we may say that what thyroglobulin we are going to follow up. But people have tried to see the thyroglobulin level absolute change. So they have found that if there is a 20% increase in the thyroglobulin level, it may be a predictor, but it is a poor predictor. It may not be the best predictor. So along with the ultrasound findings, if you are finding some suspicious lymph node, or in the other lobe you're finding something suspicious, and you also have a thyroglobulin rise of 20% or more from the baseline, you have a higher prediction. But if the thyroglobulin is not rising, then it is a better negative predictive value. The negative predictive value is to the tune of 98%. So no rise of thyroglobulin has a better prediction for not being malignant, but a rise of 20% could be a predictor in many cases, along with the findings. If you have a suspicious finding on the ultrasound, you can confirm such findings with a CT scan, because many a times we might not get the correct picture from the ultrasound. If you have a suspicion, if you are very sure that everything is going on fine, then no issues. Otherwise, go with the ultrasound, CT scan also. Also, some people have done some studies where they have tried to see the cervical lymph nodes. And what they have done is they have done a FNA of the lymph node, of the cervical lymph node, which they found suspicious on follow-up. And they have tried to see the thyroglobulin levels in that. And they have tried to do some correlation, but those are only study data. But overall, it is ultrasound, how we follow up. We see in the contralateral lobe and the lymph nodes. And thyroglobulin can be an additive thing, not going to be the predictor, because obviously we've just done a lobectomy. But a no rise of thyroglobulin is a better negative predictor to the tune of 98%.
Great. So this is for Indira. How do we follow patients with indeterminate nodule, and how often to do an ultrasound or repeat FNA if the initial decision is no surgery?
So this was actually what we were, there is a lot of controversy or confusion around this. And this is what was the highlight of the discussion. So actually, so firstly, what we do depends on a lot of factors. So let's say the patient has a suspicious indeterminate nodule, but at the same time, the other risks are there. Let's say because molecular panel is not available for us. So let's say has a history of radiation, has a family history of a thyroid cancer, has a nodule that is enlarging rapidly, is very fixed, along with certain findings that suggested, that's why the patient underwent an FNAC, because the thyroid score suggested an FNAC was done. In that case, maybe we could weigh the pros and cons, tell the patient their chances, and then maybe go for the surgery. But otherwise, let's say a lobectomy. Or maybe if the lesion seems to be extensive, maybe a thyroidectomy also. But in most of the cases, what we do is we follow up the patients. So we can review the cytology. We can reassess if the USG was indeed done properly. If it was not done properly, to do the USG, to see the scoring for the risk of malignancy. And if we're happy with all the things, then we may follow up the patient regularly. So the frequency of follow-up is, let's say, around in another 6 to 12 weeks, we may advise a repeat USG and an FNAC. So how frequently we do depends on various factors.
Thank you, Indira. There's one about calcitonin testing. How do we do it in routine clinical practice? Calcitonin stimulation test in routine clinical practice.
Can I take that question, ma'am?
Yes, please. Beatrice, that's one question each. That's perfect.
So classically, ma'am, it was pentagastrin stimulation test, but it was initially done long back in around 1970s or 80s, because we have read in the textbooks, but we have never really done a pentagastrin stimulation test, and it's not available as well. So what the pentagastrin stimulation test is now being replaced by the calcium stimulation test. So that can be done in clinical practice. So the dose will be, again, that is a controversy, because how much should the dose be? Should the infusion be for a longer time, or should it be like a shorter infusion time? So these are all controversies, but the consensus right now is that we do give calcium, elemental calcium of around 2.3 to 2.5 milligram per kilogram as a bolus infusion and as a bolus, and then we measure the calcitonin. So up to 10 minutes you can measure every 2 to 3 minutes. And then the cutoffs again are a controversy, because it is a gender-based cutoff. So the males tend to have more C cells. So they have a higher cutoff compared to the females. So the males anywhere between 1,200 to 1,500 post-stimulation, and females anywhere between 500 to 750. Again, each of these studies have had different cutoffs.
Thank you. Thank you. Indira, you said something about $5,000. So, I mean, like, for the ideal investigation treatment that will take us home, as far as the diagnosis.
No, that's why molecular.
No. This is a question, because we are trying to reach women across the globe, across the country, even in the remotest of places. So where do they send their patients for, just about all the investigation that are possible, if they can afford, if the patient can afford it? So that was, I think that's very good from their perspective. We need to know that.
Yes, ma'am.
Mm-hmm.
So, ma'am, so a proper history, proper history is very, very important. Clinical examination is very important. And I think the ultrasound and the FNAC done by experienced experts, let's say the proper, and doing FNAC in that nodule that needs an FNAC. That is also very important because sometimes every person is coming to our OPD with an FNSC done for any reason. That is not the way. So the nodule that needs an FNSC should be done. And so and in that case, our chances of a correct diagnosis becomes much better.
The molecular marker.
The molecular markers, they are not the solution to everything. Like
they just add on.
Yes,
They're
yes.
just add on
Yes,
to your entire expertise of the clinical data with the FNSC and the ultrasound that you have.
Yes.
Fair enough. Pramila, I just wanted to know what about in differentiated thyroid carcinoma? What about primary or acquired resistance to radioactive iodine? So what are the further treatment options?
Yeah, ma'am, that if we have a patient who is because most of these low risk differentiated thyroid carcinoma will mostly respond to radioiodine. But we have patients who have resistance. To follow up also these patients, many a times we have to give a higher dose of radioiodine because there are patients who have resistance to the radioiodine, but most of the times in such cases they have tried with higher doses and they have found that these patients have responded well. But other treatment they have tried, like these patients who have these resistance have a worst outcome and their 10-year survival or is mostly like 10%. So these patients don't have a very good survival, but we have some therapies which are mostly the high risk cancers where these immunotherapies and all these can be tried, like therapeutic things they have tried, like they have tried molecular inhibitors like VEGF and they have tried tyrosine kinase inhibitors. These are FDA approved for these patients. So these therapies can resensitize the dedifferentiated thyroid cancers to iodine. So FDA approved treatment for BRAF mutated patients, and these patients have been tried in anaplastic cancers mostly. But if you see the VEGF and the molecular inhibitors of VEGF and tyrosine kinase inhibitors are the common ones which we have. Actually, tyrosine kinase inhibitors is the one which we have used for resistant patients who had resistance to radioiodine.
So which ones are readily available and which ones?
Tyrosine kinase inhibitors are available, and these can be used for patients who have resistance to radioiodine. And though we know that even with that, we had patients who were having resistance and the survival is very poor. We lost that patient very soon. Like though they say that these can resensitize these even I'm not talking about the dedifferentiated cancers also to iodine, and they can allow them for radioactive iodine treatment and improve the disease control. But in one of the patients we had who was resistant, we tried the tyrosine kinase inhibitors, but we lost the patient very soon. And the survival rate in these patients is to the tune of only 10% at 5 years.
Thank you. Thank you very much. Now over to the moderator for this session, Belinda.
Thank you, ma'am. Am I audible?
Yes, you are.
Okay, thank you. So thank you very much. I'm really happy with the first session. I think it went brilliantly. I want to thank all the three speakers for accepting our invitation and giving amazing talks. I think it was a great start. So thank you, Dr. Pramila. Thank you, Dr. Beatrice, and thank you, Dr. Indra. And a very, very special thanks to Dr. Sarita Bajaj. Ma'am, thank you so much for coming today, accepting our invitation and giving us your blessings. So with that,
and thank you with this amazing team of Belinda, Vaishali, Gagan, and Shaila. Then the sky is the limit. And I think that's where we're headed. So I really enjoyed the talks and the entire session. I'm sorry about the intro, Pramila. I'm really sorry. I was thinking of Belinda and then looking at her and giving your intro, and I'm really sorry about that.
Oh, that's absolutely fine. Why should you say sorry?
Okay. Thank you. Thank you very much. Now over to Gagan for the next session.
Dr. Gagan, over to you.
Thank you, Belinda, for kickstarting the first session, and sincere thanks to Professor Sarita ma'am and all the speakers of the first session for taking us through such an interesting symphony of thyroid cancer topics. And we realize there's so much to do in the process, so much more to learn. So we'll come to a little more common area of controversies, and that's controversies in metabolic disorders in this session. And to chair this session with us is Dr. Rajeshri Janakiraman. All of us know her very fondly, and she's been both a mentor, a friend, a colleague to all of us. So Dr. Rajeshwari has done her DM in endocrinology from Lucknow after doing MD from PGI Chandigarh. She's currently a senior endocrinologist working in Bangalore and Tumkur. She's a member of almost all of the Indian endocrinology related societies. She has been the primary investigator in multiple clinical trials, and her special areas of interest are diabetes, vitamin D, calcific pancreatitis, fluid and electrolytes in the intensive care. So over to Dr. Rajeshwari.
Good evening, everyone. First of all, I would like to thank you and congratulate all these young enthusiastic endocrinologist ladies for arranging such an interesting session, which we rarely talk about actually. Okay, so coming to the controversies in metabolic disorders. So the first session will be hyperuricemia. Nowadays, we see a lot of patients coming and bringing the reports of a general health package, and you see hyperuricemia, they don't have any symptoms. So now what do we do? So to address this question, like hyperuricemia in a cardiometabolic syndrome, does the treatment of hyperuricemia, is it going to change the make a change for the patients? To speak about this, we have Dr. Aishwarya Krishnamurthy. She has done from MD from JIPMA Pondicherry and currently consultant endocrinologist at Max Hospital Vishali and Noida. And she is a very good speaker and I love listening to her. So over to you, Aishwarya.
Ma'am, thank you so much for that kind introduction. It's wonderful to be here. And I want to extend my sincere thanks to Dr. Gagan for calling me for this talk. I had a lot of fun preparing for this talk, and it was also useful because I think all of us would have seen in our practice that when we go into the OPD, when you're sitting in your OPD, however high the blood glucose levels are, your creatinines are high, the one report that all our patients are concerned about is the uric acid level, and they have to ask you, Doctor Saab zyada hai, what to do about this. So it's a very nice topic. Let's talk about this over the next 20 minutes. I'll try and share certain evidence about how we should be treating uric acid, hyperuricemia basically. So there's a fun cartoon I saw which says, "My name is Isaac Newton. I'm here to talk about the gravity of gout." So there were a lot of people who actually suffered from gout in history. And there's some very nice, interesting anecdotes which I did come across when I was preparing for the talk. So, but we'll stick to the endocrine aspects of this. So today the title of my talk would be Hyperuricemia and Cardiometabolic Disorders. Is there a role for uric acid lowering therapy? Right, so before we jump into the topic, so uric acid is the byproduct of purine metabolism. It's regulated by the enzyme xanthine oxidoreductase. And when you have a serum urate level that's more than 6.8 milligram per deciliter, that's the limit of its solubility at the physiological pH and temperature. That's important because when the concentrations exceed this, it starts to sort of crystallize, and that's where it causes the problems. And the most important sources in humans are endogenous from the purines, and the sources are from the liver, intestine, and certain other tissues. So 2/3 of this is endogenous and 1/3 is from the food that people consume, that is the exogenous purines, and mostly it's present in animal proteins. Now, evolutionarily, there's a lack of the uricase enzyme in humans, and that results in uric acid levels that are at the theoretical limit of solubility in the serum. That's around 6.8 milligram per deciliter. So this is a problem that's like very specific to humans. A little bit about the history of the emperor's malady. So the oldest record of uric acid deposition was the demonstration of the uric acid in renal calculi in an Egyptian mummy that was nearly 7,000 years old. And Aretius was the person who proposed that probably there's a toxin in the blood which is causing this disease. Anton von Leeuwenhoek had discovered the microscope by then, and he was looking at a lot of things under his microscope, and among a lot of things like, cells and, spermatozoa. And so he saw these uric acid crystals, but he really didn't know what they were until Garrod. This again was a very famous scientist. He discovered alkaptonuria, and he did a lot of work on metabolic disorders. So he found that uric acid was probably the cause of gout in patients. So this is what was the history of uric acid level. So coming to pathological hyperuricemia, so when you have very high uric acid levels, there occurs a crystallization when it supersaturates the serum, and this precipitation in different tissues, and that results in disease. Now, there are several causes for that. When you're having a very purine or a fructose-rich diet, fructose gets converted to uric acid. There are genetic and environmental factors. Also, there's an overproduction of hepatic metabolism and cell turnover, especially in patients who have certain malignancies. So these are all the causes for hyperuricemia. And at the base of this is that you have uric acid crystal formation. Now, there are certain medications that we use to reduce uric acid levels. And there are majorly of two types. One is which inhibit the uric acid production. So you have xanthine oxidase inhibitors. So you have allopurinol and febuxostat. And you have the uricose uric drugs, which are probenazide and brenzbromurone, which are commonly used. Pegloticase is another enzyme which sort of metabolizes urate to allantoin, which then undergoes renal excretion. So these are all the different types of medications that you could use to reduce uric acid levels in the blood. Now, once we've done that, so in which patients do we need to use uric acid lowering agents? So if you have a patient with gout, this was the latest ACR recommendations for management of gout were published in 2020. So we need to know whom we need to use it definitely in, whom we should not be using it in. So whom do we need to definitely use a uric acid lowering agent? So if you have a patient who has more than one subcutaneous tophi or deposition of uric acid crystals, evidence of radiographic damage, or any other modality where you're showing that this damage because of uric acid crystal deposition, or you have frequent gout flares, that's defined as more than 2 flares annually. In these patients, you need to start them definitely on a uric acid lowering therapy. Now, there are certain patients whom the recommendations tell you not to start them on uric acid lowering therapy. And this is in patients with gout who have the first flare. So you don't have to treat it at the first flare. And patients who have asymptomatic hyperuricemia. So that's what we were talking about. So several of our patients are usually asymptomatic. So in them, there is a recommendation against using it routinely in all patients, right? So then the question comes to us, why not in asymptomatic hyperuricemia, as there are several clinical and epidemiological studies which show that uric acid levels are associated with cardiometabolic disorders. So let's go through all the evidence, what evidence we have, and what exactly do we really need to treat this or not, right? So before we go into that, there are certain mechanisms through which uric acid or hyperuricemia is linked to cardiovascular disease. So you have in humans and higher apes, so you have purines, and xanthine oxidase reductase during its metabolism or its actions results in the production of oxygen-free radicals. And this results in oxidative stress, inflammation, reduction in the nitric oxide production in the endothelium, and endothelial dysfunction. Now, this could be a possible mechanism where it results in cardiovascular as well as metabolic disease. So this is how probably we presume that uric acid results in cardiovascular disease. Now, uric acid, is it Dr. Jekyll or Mr. Hyde? So why do we not have, evolutionarily, why don't we have this uricase enzyme? So why do we need uric acid? So probably they believe that uric acid also has some antioxidant effects. So we know that in several studies, uric acid has been associated with endothelial dysfunction. But there are also studies which tell us that uric acid has some antioxidant effects. So extracellular uric acid has antioxidant effects, and intracellular uric acid is actually a pro-oxidant, right? So it's in fact found that the antioxidant effect is greater than that of ascorbic acid. So it's a good antioxidant, but at very high levels, it can act as a pro-oxidant and cause the problems. Now, it's not very clear whether there's a causal role or it's just associated, whether the oxidative damage is actually resulting in the cardiovascular disease and endothelial dysfunction. We still don't know because there are several confounding factors and the exact mechanisms are not very clear, but several studies have been done. So I waded through a lot of literature, and this is what I found were important studies. So exploring the relation between uric acid and cardiometabolic disorders, the Framingham Heart Study, as we know, it's a huge study. So there are nearly 40,000 patients, and in this, the baseline uric acid did not predict future cardiovascular events. But there were other studies which did show an independent association with cardiovascular mortality. Mind you, I'm saying association, I'm not saying a causal relation, I'm just saying association with cardiovascular mortality. And There are studies which also show that it's an indicative marker for subsequent clinical events in those who have an established cardiovascular disease. So there are more, it has a prognostic impact in high-risk patients rather than a general population. Right. So when you're looking at hypertension, the risk of incident hypertension is increased by 13% for every 1 milligram per deciliter increase in the uric acid level. So this is from a large meta-analysis which involved around 25 studies. So there is an increase in the risk of hypertension with every 1 milligram per deciliter increase in uric acid levels. There are certain populations, like you have pre-hypertensive obese adolescents, those who have suffered a recent stroke or TIA, and there are certain animal models as well, where just by giving a uric acid lowering therapy, the blood pressure reduction was demonstrated. But however, this could not be replicated in other groups of patients, like those with hyperuricemia, hypertension, diabetes, and CKD. So larger RCTs did not show these effects in other larger subgroups of patients. So we can conclude that uric acid may be a causal factor in hypertension, but there's no strong evidence right now for a therapeutic intervention for lowering the uric acid to control the blood pressure, right? So there's nothing in addition to the usual standard of care of antihypertensives and dietary restrictions. There is no role for actually using uric acid reducing agent for the purpose of controlling the blood pressure. Moving on to the more serious coronary heart disease. So again, in a large meta-analysis, they found that 1 milligram per deciliter increase in serum uric acid level resulted in an overall coronary heart disease risk by 20% and increase in an all-cause mortality by 9%. And another study went on to say that this association was probably stronger in women than men. Another study showed that there was a U-shaped relation between uric acid level and both all-cause as well as cardiovascular mortality, which meant that at very low levels of uric acid and very high levels, so there's a U-shaped curve. So there are very low levels and very high levels of uric acid, both all-cause as well as the cardiovascular mortality significantly went up. But there were also studies which showed that it was not predictive of coronary heart disease or not associated at all with any cardiovascular or all-cause mortality. Again, so we're back in the same place. So further research is needed to reach a clear conclusion about both the association as well as the causality between the uric acid and the coronary heart disease. Right, now moving on to heart failure. Now there are several longitudinal studies and meta-analysis which showed that elevated uric acid is not a risk factor for the occurrence of heart failure, but it was associated with the severity and the prognosis. Now this was again replicated by the Framingham offspring cohort study, where the heart failure incidence was 6-fold higher in the highest quartile of serum uric acid, more than 6.3, versus the lowest quartile. And again, they found that a 1 milligram per deciliter elevation in uric acid increased the odds of heart failure by 19% and the risk of all-cause mortality by 4%. Right. So this was, again, there were certain RCTs which were done where they showed that allopurinol improved the endothelial function, probenecid did not. Another xanthine oxidase inhibitor called oxypurinol did not result in any improvement in clinical outcomes or scores. The EXACT-HF trial also showed that though allopurinol reduced the uric acid level compared to the placebo, there was no difference in the clinical status or the heart failure score or the 6-minute walk distances. So what can we conclude from this? That xanthine oxidase inhibition has some effect on some surrogate markers, but it does not translate into a direct clinical benefit for patients with heart failure. So it may have some effects, but right now it doesn't translate into a direct clinical benefit in patients with heart failure. Right. Now moving on to our hot topics, that is metabolic syndrome. So hyperuricemia is frequently observed in metabolic syndrome. So it is believed that this was probably secondary to the hyperinsulinemia that's seen in metabolic syndrome. So here there is a reduction in the renal excretion of uric acid by the distal tubular reabsorption. So studies have also shown that hyperuricemia usually precedes the insulin resistance. So it's not just because of the secondary to the hyperinsulinemia. The hyperinsulinemia happens first, and that results in the hyperuricemia happens first. That results in the insulin resistance, and it's an independent risk factor for the occurrence of metabolic syndrome. And xanthine oxidase inhibitors have been shown to reduce both uric acid levels as well as insulin resistance and systemic inflammation in asymptomatic people with hyperuricemia. But again, the precise mechanisms are not known, and we have not been able to replicate all these in very large studies. So right now, we don't have enough data to really make a recommendation about using uric acid lowering agents for the purpose of preventing insulin resistance or the occurrence of metabolic syndrome. Same holds true for the non-alcoholic fatty liver disease, which is again caused by insulin resistance, elevated uric acid associated with an increased risk of NAFLD. So experimental studies in animal models have shown that uric acid lowering may help in preventing the development and for the treatment of NAFLD. Again, mechanisms are not clear and we don't have adequate evidence right now to make a recommendation for using this in patients with NAFLD. Right. So the other thing we need to consider. So firstly, we don't have adequate evidence recommending us to use it in patients who are asymptomatic and have hyperuricemia. Again, if it were a really innocuous drug, you would probably think, why not use it? But these medications are not very, they do have certain adverse reactions. And most important was the CARE study. We have to talk about this study. This was the cardiovascular safety of febuxostat and allopurinol in patients with gout and cardiovascular morbidity. So they had patients who had gout and who had high-risk cardiovascular factors. And this was a double-blind non-inferiority RCT. And it was done in patients with established cardiovascular disease. There are a large patient population. And this they found that in terms of cardiovascular safety, cardiovascular events, febuxostat was non-inferior to allopurinol, but when they looked specifically at mortality, both all-cause and cardiovascular mortality, it was found to be higher in patients with febuxostat versus the allopurinol group. Now, there were several arguments about this. There was a very high dropout rate. Nearly 48% of patients dropped out of the study. And it was, a shorter duration of follow-up. So there were a lot of controversies about why this could have been. And this was followed up by several studies and meta-analysis which showed that febuxostat actually did not increase the cardiovascular mortality. But however, the US FDA still carries a boxed warning for an increased risk of death with febuxostat in high-risk cardiovascular patients. So both the xanthine oxidase inhibitors, the febuxostat does have this high risk, and so allopurinol is what is commonly used. Right, now allopurinol by itself, again, is not without adverse effects. Right, so it has a significant potentially fatal hypersensitivity syndrome, which can result in severe adverse skin reactions, Stevens-Johnson syndrome, TEN, hepatic and renal involvement. And the incidence is around 1 in 1,000 and a reported mortality of 20 to 25%. Right? So it happens within 8 to 9 weeks. Most of the patients develop this if they're going to develop it. So to prevent it, the ACR and the EULAR recommend that you start at a low dose and increase it very slowly. You start at around 100 milligrams and increase it slowly, say around 100 milligrams per month. And you go slow till you reach your targets. Now, other uric acid lowering therapy are generally not used in patients with asymptomatic hyperuricemia. So it's mostly the xanthine oxidase inhibitors which are used. And because of the black box warning, allopurinol supposed to be used more than febuxostat. Right. Now, so you will be thinking, are there any actual indications for uric acid lowering in asymptomatic hyperuricemia? Yes, they are. So this was a very nice article I read from this journal. And here they mentioned that there are 3 indications where there is adequate evidence to consider using allopurinol for asymptomatic hyperuricemia. I think this is important for all of us in our practice. So if you have persistent uric acid levels, that's more than 13 milligram per deciliter in men and more than 10 milligram per deciliter in women, you could put this patient on a uric acid lowering therapy because there is a nephrotoxic risk, and the renal disease progression and the nephrotoxic effects could be prevented or slowed by the use of allopurinol. The second thing is the urinary uric acid excretion of more than 1100 milligrams per day. In this situation, there is a 50% increased risk of developing uric acid calculi. So this can be prevented if you're reducing the uric acid excretion to around 800 milligrams per day. So this is another indication. And the third is if you have a patient who's planned for radiation therapy or chemotherapy. So in this situation, we are all familiar with this situation. So use to prevent uric acid nephropathy and other manifestations of tumor lysis syndrome, it can be used. One note of caution, if you're using it with azathioprine, you need to be careful because xanthine oxidase is what metabolizes azathioprine. So when it's inhibited, the levels of azathioprine reach very high levels and it causes a very significant and fatal, sometimes hematological suppression. So we need to be careful and start at a very, very low dose of allopurinol, maybe 1/3 or 1/4 the doses. So you need to be very careful when you're using allopurinol along with azathioprine. Right, so with that, I'll conclude my talk with just a few take-home messages. So elevated serum uric acid level can be associated with certain cardiovascular diseases. Association has been shown in several studies. Again, causality is still controversial. There are certain benefits. So there are marked indications where you need to use it to treat hyperuricemia, some where you don't have to treat. In asymptomatic hyperuricemia, there are certain indications which we talked about, but the other indications, there may be some suggestion on the basis of surrogate endpoints, but its translation into a clinical improvement has not been shown as of now, so it should not be routinely used. And again, further studies are warranted to see whether we can actually use it to prevent cardiovascular risks. So with that, I'll wind up my talk. I thank you so much for your patient hearing.
Thank you, Aishwarya, for a very lucid presentation and also bringing out the interesting, history behind that. So what I can understand, summing up, is there is controversy about the causation and the effect on the metabolic syndrome, various components. But treatment-wise, I don't think any controversy is there. As a treatment for metabolic, it's mainly for other reasons of hyperuricemia. So I think we will take the questions at the end. We'll go to the next talk in this session. This is about low testosterone and obesity. What comes first? So we do get a lot of patients who are obese men get a health package again for vague reasons, and we see their testosterone is slightly low. What do we do about this, these patients, and what is the cause? Is it the obesity that is the cause for this low testosterone? To talk about this, we have Akshata Desai. She is American board certified in medicine and endocrinology and diabetes. She is a consultant at Apex Hospital, Jalandhar. Over to you, Akshata.
Thank you, ma'am, for that kind introduction. Let me just share my screen real quick. So at the outset, I'd like to thank the organizers for this wonderful opportunity to share the dais with all these beautiful ladies. So I'll go right ahead. Are my slides visible?
Yeah, we can see them. Proceed.
Okay, yeah. So the controversial topic I'm going to be talking about is low testosterone or obesity, what comes first. And like Dr. Rajeshwari already pointed out, we have a lot of young, obesity is an epidemic nowadays. We have a lot of youngsters coming in with very non-specific symptoms, and they've already, they've said they've Googled and they've checked testosterone levels need to be checked. They've already checked it and they come to see us. And I face this quite often. And then, often we're in a dilemma as to what to do with these individuals. They haven't even started planning their family. They've got low borderline testosterone levels. So what's going on? Is it the low testosterone or the obesity? What's going on? So the next 15 minutes or so, let's try to understand this concept a little bit better. So what do we know? We know that at least 1/3 of men with obesity, metabolic syndrome, and diabetes have low testosterone levels. So multiple studies have already shown us this. We know this. We also know that low testosterone predisposes to obesity and insulin resistance. So really, that doesn't help us, right? Because we're stuck in a situation to see what came first. Is it the chicken or the egg? Does hypogonadism lead to insulin resistance and metabolic syndrome? Or does metabolic syndrome and diabetes cause low testosterone levels? Let's look at that. So to look at this, let's look at the effect of testosterone first on the glucose metabolism. So we know GLUT4 stands for it's one of the glucose transporters located on the myocytes, cardiomyocytes, and the adipocytes. So testosterone increases the expression and the translocation of GLUT4, improving the glucose uptake. So it has a positive effect on the glucose metabolism, adequate levels of testosterone. Not just that, we have androgen receptors present on the beta cells in the islet, And this results in increased glucose-dependent insulin secretion, so it enhances the action of GLP-1. So normal amount of testosterone levels in the body through the androgen receptor on the beta cell causes a GLP-1-like effect and increases the glucose-dependent insulin secretion, reducing inflammation, improving overall beta cell health, and decreasing the risk of diabetes. So it's also interesting to see that the same testosterone in the woman, in a female, works differently. So the same androgen receptor present on the beta cell, the testosterone levels, increased testosterone levels in women results in insulin hypersecretion, mitochondrial dysfunction, oxidative stress, and beta cell dysfunction. Interesting. What else do we know? Just delving into this further, we know that testosterone has an effect. It promotes on the pluripotent stem cells. It promotes the conversion of these stem cells preferentially to myocytes rather than adipocytes. So we have normal amount of testosterone level in a male results in good muscle mass and less fat mass, right? So when there is a testosterone deficiency state for whatever reason, right, there is increased adiposity, which results in insulin resistance, a metabolic syndrome-like picture. Now, when you have severe testosterone deficiency in the androgen depletion therapy, so in somebody with advanced prostate cancer who's on androgen depletion therapy or somebody who's on GnRH agonist, this within a span of a year can result in such severe beta cell dysfunction, resulting even in diabetes. So the converse is also true, that lack of testosterone in moderate levels will result in just insulin resistance and a metabolic syndrome-like feature, and severe testosterone deficiency can even result in beta cell dysfunction and increase the risk of diabetes. So now that we've seen the effect of testosterone on the glucose metabolism, let's look at the vice versa, the opposite, the effect of diabetes and obesity on testosterone levels. It's a little more complex here. So we all know obesity is a chronic inflammatory state, right, where you have increased cytokine levels of TNF alpha and interleukin 1 beta. These have been shown to suppress the GnRH levels, in turn suppress the LH levels and suppress testosterone levels. We also have obesity, which is an insulin resistant state. There's leptin resistance here. Both have a GnRH suppressing effect. Sleep apnea, which is a very common comorbidity in obesity, also has a similar effect on with suppression of the HPG axis. We have some peripheral factors. So with increased adiposity, we have increased leptin levels. Leptin has a direct effect on the Leydig cell. It suppresses the Leydig cell and it decreases the responsiveness of the Leydig cell to LH. Again, decreasing testosterone levels. Increased adiposity, increased aromatase levels, increased estradiol levels can also have a negative feedback, though this area more recently has become slightly more controversial. And we also have peripheral testicular factors, where there is increased local temperatures causing suppression of spermatogenesis and decreased sperm function and motility. Also, some thoughts about increased fat diet in obesity leading to gut endotoxin production having a direct suppressant effect on the testis itself. So there are multiple factors associated here. So it's also important to understand when we're dealing with hypogonadism, whether it's obesity or not, is it organic or is it functional? So it's also important to understand the difference. Organic hypogonadism is where there is an organic cause identified, where there's a structural cause, an established disease state that has been identified, such as in case of secondary hypogonadism, it's usually a pituitary tumor that's there. In case of primary hypogonadism, it's usually there is either a tumor, there's a Klinefelter syndrome. So in these situations, the symptoms are also more specific. They have specific symptoms of low testosterone, like low libido, smaller testes, gynecomastia, and the levels are also much lower, and replacement is recommended in these cases and shows benefit. What about functional hypogonadism? Functional is where there is a functional suppression of the HPG axis. So here, where there is no structural cause or no organic cause that has been identified, which is why it is called functional. Here, the symptoms are also quite non-specific. They have just low energy, they have suppressed mood, erectile dysfunction, maybe low libido sometimes. The levels are also not that low, they're borderline, they kind of tend to fluctuate a little bit. And these conditions are potentially reversible. So if you actually identify the cause that is there, then yes, by acting on that cause, be it obesity or be it diabetes and working that out better, treating that, they are potentially reversible, which is why testosterone replacement is not routinely indicated in these situations. So functional hypogonadism in a case of obesity or diabetes, that's something we see most commonly in our practice, where this question arises whether to treat or not, right? So let's, hold that question in your mind, and let's move on to this study. This was a recent study that was published last year. Remission of type 2 diabetes following long-term treatment with injectable testosterone under canoate in patients with hypogonadism and type 2 diabetes. It's an 11-year real-world registry study. It's actually conducted by two of my mentors in Buffalo, Dr. Sandeep Dhinsa and Dr. Paresh. It's very dear to me, the study. So what they did here was, it was a prospective registry study. They had about 370 patients here, not a very big study, but these individuals had type 2 diabetes for a short duration, about 60 years of age, and they all had hypogonadism and they had symptoms of hypogonadism. They had average testosterone levels to the order of about 250 to 260 nanograms per deciliter. And the cutoff here was about less than 350. Total testosterone levels were used as the cutoff, less than 350. And they chose to either go with testosterone replacement or they chose not to go with testosterone replacement. And these individuals were followed for a whole 11 years. And let's look at the remarkable effects testosterone had in these individuals. So here we see the green line is testosterone replacement therapy. We see the fasting glucose levels steadily declined in the group on testosterone by 1 year and by 2 years, and then it stabilized and remained the same over the course of follow-up by 11 years, versus those who are not on testosterone therapy remained the same, and then over time, the levels of glucose, fasting glucose, climbed up. Here, the A1C levels also steadily declined, continue to decline all through the course of treatment up until 11 years, versus those without treatment actually increased. So there's actually a net 6.7% change in the A1C levels between these two treatment groups. So we also see here that there was almost about a 22 kg reduction in the testosterone group over time, about a 6 kg increase in the control group, net 29 kg difference between the two groups. There was a 3-point reduction in A1C, 3% increase in A1C, resulting in a net 6.7 reduction in A1C between the two groups, and also a positive effect on the cholesterol profile as well that was seen between the two groups. It was also interesting to note that 1/3 of patients even achieved remission of type 2 diabetes over the course of treatment, and remission was achieved at about 8 years. So it took 8 long years. So you can see right from here, starting out here to about 8 years was how long it took for medicines to start, for them to be able to stop the medicines. Very, very long treatment. And that's probably why we don't have such long-term studies, and we have not seen such data because they've not been followed up for that long. So 91% of patients achieved A1Cs of less than 7, 83% less than 6.5, 46% were in normal glucose regulation, and 34% achieved remission at 8 years and remained in remission for the rest of the 2.5 years. And also the use of testosterone also showed a survival benefit here. So multiple benefits to the use of testosterone in the right population, even on metabolism and to the point of diabetes remission. So with all this in mind, let's understand how to use this in our clinical practice. How do we be vigilant about glucose metabolism in those with hypogonadism? So in those on androgen deprivation therapy in prostate cancer, we want to understand how the risk increases. So within 3 months of ADT commencement, there's an increased visceral fat associated and increased insulin resistance. By about 1 year of therapy, there's already an increased risk of diabetes because of the significant beta cell dysfunction. So all of these should be screened for diabetes, hypertension, and dyslipidemia every 3 to 6 months. So anybody on androgen deprivation therapy, make sure we're screening them for diabetes frequently. What about those with hypopituitarism? So here there are multiple other factors that result in alter the insulin sensitivity. Of course, they're also getting growth hormone replacement. Some of them, they're also getting glucocorticoid replacement. So there's no standard guideline in those who are not on growth hormone replacement. But those on growth hormone replacement, of course, we all know that every 6 months we need to check blood glucose levels. For the others, screening needs to be individualized. Klinefelter syndrome is unique in primary hypogonadism because it's independently also associated with high insulin resistance. So 1/3 of these individuals already have abnormal GTT. There's also a high incidence of autoimmunities, 2.5 times higher prevalence of type 1 diabetes than the general population. Type 2 diabetes also occurs a decade earlier, has a higher mortality, and testosterone replacement in these individuals can delay the development of diabetes. So surveillance in Klinefelter syndrome makes sure that at diagnosis itself, they're screened for diabetes every 3 months for the first few years and then annually. And even if they're on testosterone therapy, they need to be screened. And treatment is preferable with metformin and GLP-1 receptor analogs as compared to insulin or sulfonylurea. Hypoprolactinemia, something we see quite often resulting in secondary hypogonadism, also an independent state with associated with insulin resistance and an increased risk of diabetes. So make sure we're screening for diabetes in all our patients with hypoprolactinemia at baseline. And of course, dopamine agonists do not only help with the prolactin, but also reduce the risk of diabetes. Now, what about exercising gonadal vigilance in individuals who have diabetes and obesity? So should all men with metabolic syndrome and diabetes be screened for hypogonadism? No, the Endocrine Society guidelines do not recommend routine screening. However, screening is recommended in select individuals, especially those who have osteoporosis, infertility, and those with symptoms of hypogonadism. So any of our patients with diabetes or obesity, I think it's more of aggressive case finding because you can make a difference. So if they have symptoms of if they have osteoporosis itself, they have infertility, and if they have any symptoms of low testosterone, erectile dysfunction, decreased libido, then yes, they absolutely need to be screened. How would we go about it? Not a random testosterone level. We always check morning fasting total testosterone levels because it has a diurnal rhythm and it should be fasting and in the morning. Both are equally important. And you will also want to get SHBG levels and albumin levels because a good amount of the testosterone is actually bound to SHBG and to albumin. SHBG levels tend to be low in insulin resistant states like diabetes and obesity, which is why free testosterone, which can falsely lower your total testosterone level in these situations, which is why free testosterone is the best assay, but you have to use an equilibrium dialysis method for this, which is not routinely available here. So the other way to go about it is get a total testosterone, SHBG, and albumin, and use a calculator to calculate the free testosterone levels. And if you get one level, you're not done right there. You have to confirm it with another level and also add on an LH, FSH, and a prolactin to identify whether it is primary or secondary, and then go ahead and treat. So secondary hypogonadism, in cases of secondary hypogonadism, when will you order an MRI pituitary? Of course, if the levels are too low, less than 150 nanograms per deciliter, if they have an elevated prolactin already, especially more than 100, if there's any other evidence of anterior pituitary hormonal dysfunction or symptoms of mass effect. So to summarize now, I'd like to say, yes, we know obesity, metabolic syndrome, and type 2 diabetes, they have a bidirectional association with testosterone levels. We know that having low testosterone in androgen deficiency states does result in an insulin resistance metabolic syndrome kind of a picture and severe testosterone deficiency in ADT can even result in increased risk of diabetes, which is why it's important to screen for diabetes in these individuals every 3 to 6 months, especially in ADT and Klinefelters. On the other hand, we also know that obesity and metabolic syndrome, because of the chronic inflammatory state that they're in and insulin resistance and leptin resistance, they do result in hypogonadal state due to multiple central factors and peripheral factors. So yes, it does predate the development of functional hypogonadism. Is screening indicated in everybody? No, only in those who have symptoms of hypogonadism. Screening is indicated, or if they have osteoporosis, or if they have infertility, and you always confirm that level with an LH, FSH, prolactin to ensure what you're dealing with, primary or secondary. If you get primary, then you always get a karyotype to confirm if they have Klinefelters or not. So you identify even if it is organic. If you have secondary, then you will see the levels. If there's prolactin elevated, you will also confirm if there is a pituitary tumor. If there is any organic cause, treatment is absolutely indicated. And if there is no organic cause, then it is functional hypogonadism. Yes, we've seen a recent study where there was individuals with diabetes and functional hypogonadism, yes, treating them with testosterone replacement did result in diabetes remission in over 1/3 of patients. So yes, the chicken and the egg philosophy, we have to understand you cannot generalize it. It has to be individualized per patient. If somebody starts out with androgen deficiency, yes, they want to have a metabolic syndrome and diabetes. And if they start out with obesity, yes. So I think clinical history, exam, and putting everything into perspective is very important to be able to help these individuals. And you cannot just look at them as one cross section. So I'll end there, and we'll probably take questions in the end. Over to the organizer.
Thank you, Dr. Akshata, for a very clear presentation and lucid explanation. It was very good. So the controversy about whether to treat patients with low testosterone, it depends upon the presence or absence of the metabolic syndrome components, I suppose. Okay, we'll go back to the questions later. So for the next and the last talk of this session, we have Dr. Aditi and Dr. Saurabha Bhatt. So Dr. Aditi is done a DMB from endocrinology in Army Hospital, R&R, New Delhi. She is currently consultant endocrinologist at Narayana Super Specialty Hospital at Nanded. And we have Dr. Saurabha Bhatt. She is DM endocrinology from IPGMER, Kolkata, and currently consultant endocrinologist at Chinmaya Mission Hospital in Bangalore. Welcome both of you. So we have the topic of non-alcoholic fatty liver disease versus the metabolic associated fatty liver disease. So last year this term has been coined as a metabolic associated fatty liver disease. So is NF a part of the metabolic syndrome? What do you ladies?
Thank you, ma'am, for such a kind introduction. And me and Saurabha here would like to thank the ESI and Gagan ma'am, Vaishali ma'am, Belinda, and Sheila ma'am, of course, for giving us this opportunity to speak on this forum. I will share my slide. Good evening, everybody. Today, myself, Dr. Aditi Kabde, and Dr. Saurabha, we will be taking you through the discussion of a relatively new topic, that is metabolic dysfunction associated fatty liver disease versus non-alcoholic fatty liver disease. Now, whether they are the same, whether this new nomenclature, does it describe everything, or is NFLD the hepatic component of metabolic syndrome? Now, historically, NFLD has been defined as evidence of hepatic steatosis by imaging or histology, and there is absence of secondary factors of steatosis, be it viral inflammation, viral markers, any medications, and most importantly, any significant alcohol consumption. Now, as you can see, there is a lot of heterogeneity amongst the various guidelines, and the most important difference in all the guidelines is the kind of the amount of alcohol consumption, which varies from place to place. And also there is no clear metabolic factors which are mentioned except in the European Association guidelines, which are kind of recently introduced the term of insulin resistance. So NFLD, as we all know, has been classified into two subtypes, essentially, that is a non-alcoholic fatty liver and the NASH. That is NASH, which includes the steatosis, inflammation, and the ballooning. And further, it is graded down into steatosis with inflammation, early NASH, fibrotic NASH, and in the end, it is a cirrhosis. So in all this classification, the most important thing which is seen in patients with NASH is that they have increased liver-related mortality rate. So this NFLD, those patients who have NASH, that is steatohepatitis, have an increased liver-related mortality rate. And also the most important feature of NFLD is with long-term mortality rate is the presence of fibrosis. So if there is presence of fibrosis, then the chances of you dying are much more. Now this kind of doesn't really describe it. So there is multiple metabolic associated liver diseases which are associated with NFLD. Saurabha will be talking about them.
Yeah, so we have heard the term now that it is MAFLD, but NAFLD is an old disease and it has always been metabolically associated. So we have seen that metabolic syndrome components like obesity, type 2 diabetes, dyslipidemia, these are all risk factors for NAFLD. This has been long known, it's not a new thing. And features are highly prevalent. Features of metabolic syndrome are highly prevalent in NAFLD. Like, for example, in diabetics, up to 70%, like 1/3 to 2/3 of diabetic patients have NAFLD, that is known. In fact, there is a bidirectional association between NAFLD and type 2 diabetes. We know that NAFLD is common in diabetics, the reverse is also true. And regarding obesity, for example, more than 95% patients undergoing bariatric surgery will have NAFLD. And in case of dyslipidemics, up to 50% patients have NAFLD. So this is a well-known association. Other than diabetes, even there is an association, bidirectional association with the other components of metabolic syndrome. And one more association that is commonly seen is well known is that metabolic syndrome is a strong predictor for the presence of steatohepatitis. So when we look at the indications for liver biopsy, like the commonly used blood biomarkers, along with that, even metabolic syndrome is a predictor of the presence of steatohepatitis. So it can be used as an indication to target patients for liver biopsy. That is one more association. And also what is known as the increasing number of components of the metabolic syndrome, like insulin resistance, type 2 diabetes, hypertension, dyslipidemia, increases the risk of progressive liver disease. But as per the guidelines, actually, routine screening of NAFLD in these high-risk groups is not advised. However, there is what is mentioned is a high index of suspicion for NAFLD and NASH is needed in type 2 diabetic patients.
So as you can see, there are a lot of deficiencies in the definition. Now, going back to the time when NAFLD, the term was coined, it was coined way back in the 1980s, when a lot of clinicians and histopathologists observed certain histopathological similarities with the alcoholic liver disease. Well, a lot of water has gone down the bridge since 1980s, right from the couch potatoes to our dietary habits, to the way we live, internet, everything has gone a sea change. And metabolic abnormalities, metabolic dysfunction is forming an important role in all the disorders across the board. Now, also NAFLD is a negative nomenclature. The term non-alcoholic liver disease, that alcohol itself has a very negative tone to it, connotation to it, especially in our country, Indian country, and also the Middle is considered as a taboo. And also, if you give the diagnosis of NAFLD, to women and children, young children, that can cause a lot of confusion. Because what happens that when you tell a patient that you have non-alcoholic fatty liver disease, so they say, yeah, okay, I don't drink alcohol, but why do I have this fatty liver disease? Why do I have the NAFLD, what you're calling? So the definition itself is, they have defined it as a disease of exclusion. Also, what they have defined is that they have kind of all the guidelines. Of course, the amount of alcohol consumption has varied. Like it is 20 grams, somewhere it is 7 drinks, it is 14 drinks, 1 drink, 12 ounces. The amount of drinks has varied across the definitions. But what they have defined is that whatever across, like say in the European and American guidelines, 20 gram and 30 gram is used. 20 gram is for females and 30 grams is for the 30 gram is for males. And they have said that anything below 20 gram or 30 gram is okay. It is okay. We don't really know what happens when you drink say 19 gram of alcohol. So the amount of alcohol consumption and the kind of liver dysfunction it causes has not yet been clear. Also, there is an increasing prevalence of metabolic dysfunction and also alcoholic liver disease. Now, those patients, subset of patients who have alcoholic liver disease and they have metabolic dysfunction, rather like they are obese or they have type 2 diabetes or they are overweight, they tend to progress faster. So there is a definite connection of metabolic dysfunction with of alcohol. So that's why experts from all over the world, they were kind of like, this NFLD does not really tell us everything. I'll tell you a story that there is a brother named Ashant in our hospital. Now he's anything but Ashant. You know, his name doesn't really tell you what he is. So it is something that with NFLD doesn't really tell us what is actually happening, and actually it is the metabolic dysfunction which is the driver force for this fatty liver disease. So that's why they came up with the term of metabolic dysfunction associated fatty liver disease.
Yeah, so like how Dr. Aditi described, there are a lot of deficiencies in the definition of NAFLD. The term itself makes us neglect this. So we came up with what a lot of experts came up with the positive criteria for diagnosing it. Actually, this attempt to give it a different name was there from 2002. If you look at the history, like ever since 2002, experts and the European Association of Liver Disease, study of liver diseases, they've all tried, but somehow it was not executed. And in 2019, actually, Eslam and colleagues came up with a proposal for a consensus. And in 2020, it was published. There was a consensus statement that published a definition for MFLD. So these are the positive criteria. So one essential criteria is hepatic steatosis should be present, detected either by imaging techniques, blood biomarkers or scores, or by liver histology. We don't, of course, commonly do liver histology. We don't straight away do it. The other two. Along with that, diabetes should be there, or along with hepatic steatosis, overweight or obesity should be there. If neither of these two are present, if the patient is lean and non-diabetic, then we need at least two of the metabolic risk factors that are mentioned. That is, there are 7 criteria. Most of them we are very familiar with: waist circumference, the blood pressure, triglycerides, the HDL, pre-diabetes. We know clearly all the cutoffs, and along with that, the HOMA-IR score, which should, if it is more than or equal to 2.5, and the HSCRP levels, if they are more than 2. Actually, except for the last 2, the others are commonly done. So it can help us diagnose using these positive criteria.
So now coming to decoding the criteria, like why these criteria have been used for this MFLD definition. Now, body weight, as you saw, is first is of course the hepatic steatosis. That is that of course goes without any explanation. But the remaining criteria, that is the body weight, is an important factor which you have considered. As we all know, excess body weight means more of adipose tissue, more inflammation, chronic inflammation, oxidative inflammation starts, and leading to fatty liver disease and progression, insulin resistance, all those things. So that we know that it is a critical determinant of adverse clinical outcomes. And as we all know that obesity as such can be divided into metabolically healthy obese or metabolically unhealthy obese. And of course, there is a huge controversy in this also, that we can have a whole lecture about metabolically healthy obese and how to define it. But metabolically healthy obese, they found out that even in patients who are supposedly metabolically healthy, those also have associated fatty liver disease compared and they classify for the MFLD criteria. So they also have high risk of, they have fatty liver disease, and they also have a significant risk of hepatic fibrosis. Like already Saurabha she has mentioned that type 2 diabetes, more than almost 70% of the patients have diabetes. So I guess that is also included in the criteria. And another thing regarding the weight, it is that always we have in mind that thin is healthy. Now, when I was preparing for this slide, since I am thin, I always thought that, oh, I am healthy. Probably I may not be, because almost 6 to 20% of patients who are lean individuals, but who have 1 or 2 of the metabolic risk factors, almost 6 to 20% of them can have some fatty liver disease. And that is a very disheartening thing to learn for me. But anyways, it is. Also, as we know that liver injury is a continuum, and like in the starting, how the definition, they have divided into non-alcoholic fatty liver and non-alcoholic steatohepatitis. But as such, liver injury is a continuum. Just like how HbA1c is a continuum, there is no specific no specific cutoff, like 6.5 you develop complications, or 7 you start developing complications. It's a continuum. So it is best described by the grade of activity and staging of fibrosis, which is seen in most of the other GI disorders. There is always grading of activity and the staging of the fibrosis. So that's how these MFLD definition criteria have come about.
Yeah. So, like Dr. Aditi has explained, how she has clearly explained the components of the new criteria. Along with that, what has been mentioned in the consensus is an added scope for inclusion of other etiologies. So, in NFLD, we had to exclude other things. Actually, it is a very artificial thing. In the sense, one person can't have only one disease and not have other disease. We can't be sure of all that. So if alcohol liver disease is not at all, we have to exclude other conditions, steatogenic conditions for NAFLD definition. But with the rising prevalence of MFLD, coexistence can occur. That can occur in any other disease. So for example, alcoholic patients may have MFLD also. So what the scope is, dual etiology fatty liver disease, that is concomitant MFLD and other liver disease also. So we can make this diagnosis. This is the added scope of this new criteria. For example, MFLD along with alcohol liver disease, along with the viral infections, autoimmune hepatitis, inherited disorders. So whatever other diseases were supposed to be excluded to make a diagnosis, now we can have a combined diagnosis. That is an added scope by this positive criteria. So how does the change in this definition translate into clinical practice? It's not just the name. So it should translate into our practice. So does it really help? Let us look.
So this has been a recently published study. It is a comparison of the MFLD and the NFLD diagnostic criteria in real world. They used the NANES3 database, which had almost around 13,000 patients. And what they found out that almost when they applied the MFLD criteria, that is the metabolic dysfunction associated criteria, and even the NFLD, the old NFLD criteria, both of them, see, NFLD also kind of picked up around 4,000 patients, and even the MFLD kind of picked up around the 4,000 patients. Now, what important factor in this study was that be it whichever criteria, be it MFLD criteria or the NFLD criteria, those patients with fatty liver disease had always, they were likely to have higher BMI, older, more likely to have insulin resistance, metabolic comorbidities, elevated liver enzymes, elevated HuMA levels, elevated HSCRP levels. All these things were there with fatty liver disease. So irrespective of the criteria which you used. Another thing what they found out in this study, that this subset of patients, that is those where MFLD criteria were not applicable, only they fit into the NFLD criteria. That is, those patients were kind of younger, they were having lower BMI, they were having better metabolic profile, and they were having less severe fibrosis. So this kind of is heartening for even the MFLD definition, that by in chance, if you miss also these patients because of using the MFLD criteria, these are the subgroup of patients which are likely to have less severe fibrosis and less progression of the disease. Also, the other group, that is those which classified with the MFLD criteria but non-AFLD group. Now, all these patients were younger, they're predominantly males. They had a better metabolic profile, but however, they had more severe fibrosis and they were likely to progress faster. They're likely group which does not go into non-MFLD and NFLD. It is probably all those viral infections or cryptogenic which you have labeled, or any drug induced. This is the white group. One important factor which they found out, that like how MFLD kind of doesn't differentiate with the alcohol intake. So those patients with MFLD who had metabolic fatty liver disease, but who had mild to moderate amounts of alcohol, according to the definition, like they had less than 20 gram or less than 30 gram of alcohol, these dual insults resulted into a faster progression. So this is one factor which can be used to, like especially if we find our obese diabetic coming to our clinic, and if we are finding him to have fatty liver disease, and he is taking like say moderate amounts of alcohol, we can put a hammer in his brain that you have metabolic syndrome, you are taking alcohol. If you do this, then you're likely to progress faster. So also this another study also which used an NANES data database, they had similar findings, but one thing they found out that those MFLD patients were also associated with increased cancer-related mortality.
Yeah, like this is another study, like how Dr. Aditi explained, but that was based on the NANES data. But here, this is a prospective study. This study was done around roughly 3,000 patients from Sri Lanka. So the genetic makeup of these patients can be more or less compared to Indian. Indians' genetic makeup. So we'll get some more data in this based on this study. And in this study, what they did was they divided patients. They saw the patients at baseline and again after 7 years. They followed up the patients and they studied them after about 7 years. So here they categorized patients as diagnosed by NAFLD but excluded by the MAFLD criteria, and vice versa, like diagnosed by MAFLD and excluded, and there were controls who did not fit into either. So what they saw was compared to patients who were diagnosed by NAFLD and excluded by MAFLD criteria, the ones who were diagnosed by the MAFLD and excluded by the NAFLD had higher metabolic derangements at baseline. And after 7 years, both these groups had higher cardiovascular events compared to the controls, but those who were diagnosed by the MAFLD had criteria, had higher cardiovascular events. Plus the incidence of other metabolic derangements like obesity, type 2 diabetes, all these were higher in the MAFLD. But they were only diabetes was slightly on a higher side in case of NAFLD, but excluded by MAFLD. So what we can see is higher risk patients are diagnosed based on the MAFLD criteria. So what are the pros by using these criteria? So in the awareness campaign, so once we label them as metabolic associated fatty liver disease, the awareness goes up. So naturally we have a tendency to think, okay, that etiology is mentioned in this. So it was always a neglected definition, NAFLD, non-alcoholic disease of exclusion. Also, it focuses on the intervention, like lifestyle modification. So in early stages like of steatosis, these help. So that will focus on the interventions.
Also, the another thing which is there, that the NAFLD criteria may suggest that a certain amount of alcohol consumption is acceptable. This is what I mentioned just now. And there is no robust demonstration of the existence of safe threshold, which has kind of come out with this MFLD definition, because the MFLD patients with alcohol, they progress. This is what we have learned. And also the new MFLD criteria focus on the role of dysmetabolism on hepatic fat accumulation. And what we see is that this fatty liver disease, now this kind of gets us to the point where whether fatty liver disease should be included in the metabolic criteria when we are talking about how do we define metabolic health, and whether this fatty liver should be included in the criteria of how we include like fat, triglycerides, HDL, whether this should be also included in the criteria.
Yeah, there are disadvantages, of course. So by labeling it as this, as it is, there is a lot of confusion. It's a neglected area. So a lot of physicians don't give a lot of importance to this NAFLD. And now again, within no time changing it, that can lead to confusion. Also, more than the nomenclature, the consensus was based on nomenclature. There should be more awareness of the public and general awareness, and prioritize on the intervention. What can be done about the disease?
Also, alcohol metabolism, what you can think, like what doesn't really work in favor of MFLD definition is that alcohol metabolism has always been an important liver disease. So how does this kind of correlate with alcoholic liver disease now that it comes under the rubric of MFLD? Also, there are the lean patients, which kind of come into the definition of MFLD. Now, while I was going through, there is a whole role of gut microbiota and the genetics, which also play the role of MFLD, because, okay, we have fatty liver disease, but some of them, they kind of progress and some of them, they do not progress. So probably it is the genetic association. There is a vast studies which have been performed, genome studies which have been performed, and they found out multiple factors which some patients which progress and some which don't. So these things have not been considered in the MFLD definition.
Yeah, so with this, we can conclude that NFLD is an oversimplified term which does not match the current understanding of the disease. It's a non-disease or an exclusion disease. And the new term, that is MAFLD, represents an umbrella for describing a spanning spectrum of disease and clearly establishes that it's clear that it is a metabolic disorder. However, just renaming should not happen. Along with that, hand in hand, awareness for the fatty liver disease should go on, and so this will shift even the naming and diagnosis in the coming research projects. Also, it will make a huge difference. Thank you.
Thank you, Dr. Aditi and Saurabha, for giving a very clear picture of the whatever the old disease in a new name. Of course, it was not just that from your talk. It is much more. Previously, I remember as a medical student, we would say, yeah, NASH is okay. If it's alcoholic, it's a problem. It's NASH, it's not a problem. That was the time it was. And over years, we realized the importance of that NASH or non-alcoholic fatty liver disease. And I think what it brings out from your talk is the importance that we have to give even for this to prevent, create awareness or treat these patients. Though we don't have a specific treatment, of course, we'll start looking at, even if the patient doesn't have any problems, we'll try and look into the metabolic factors and take care of that. I think that is what that you brought about. So we'll go ahead with some of the questions that we have in the chat box for all the other talks also. Basically, I think one of the questions about for Aishwarya about hyperuricemia. If the patient has hyperuricemia and they have metabolic disorder or diabetes, would SGLT2 be one of the choices? Could it be the one of the criteria for that?
And it's a very nice question, actually, because this is something that I didn't cover in the talk, but there has been a lot of work done on SGLT2 inhibitors and how they're actually a very good uricosuric agent. They're not as robust in their uricosuric action as the xanthine oxidase inhibitors. The mechanism of action is different, of course. So they have a more uricosuric action as compared to the xanthine oxidase inhibitor. So they actually have like a combined additive effect if you're using them together. So it is one of the mechanisms where we are thinking that probably SGLT2 inhibitors, the cardiovascular benefits, it's one of the things that they're discussing, whether it could be because of the uric acid reduction that they actually result in the cardiovascular benefits or not. So yes, it's a very nice question. And I think that would be a future direction. I mean, that would be one of the other things that SGLT2 inhibitors do in addition to all the other remarkable things it seems to be doing.
The exciting molecule, though, as a class, yeah. So, but it may be very difficult to say that is the only cause, because blood pressure reduction, so many, obesity reduction, so many things come into picture also. So that is good. Then coming to, I think one of the questions was what happens to SSBG in obesity. I think it has been addressed. Akshata Desai actually in her talk, she covered that. SSBG does, due to insulin resistance, it does. You want to take any more, give more, comments or, details about this?
I think all insulin resistant states result in a low SHBG level, be it obesity, diabetes, even PCO. All of these states do have a low SHBG, and that is why the total testosterone levels are not so reliable, because a good amount of it is bound to SHBG. So in these situations, ideally a free testosterone level needs to be checked with a reliable assay, which is equilibrium dialysis. Unfortunately, we don't have that available here, and the routine assays that are being used are not accurate. So the way we can go beyond that is get total testosterone levels, SHBG and albumin checked, and use a calculated free testosterone level through a free testosterone calculator. So the one I personally use is from Dr. Kaufman, it's a Belgian calculator. So this helps because we know that in males we need about at least 2% of the testosterone is free, versus in females it's 0.7%. So in males, so if you use all these parameters, you just have to plug in these 3 different parameters and you get a estimate of the free testosterone level, calculated level. So that would give you the best estimate that we have available so far.
And how about treating pre-diabetic? These patients, some of these who come with the health package and you see the testosterone like this, pre-diabetic, if they are, would you like to treat them with testosterone?
Pre-diabetic with low testosterone?
Yeah.
So they have
the prevention.
What's that?
For the prevention of of diabetes or reversal.
So
Dr.
Adishwari, I think that's very controversial. The study that we had was a prospective registry study, but it was excellent in the kind of results that it showed. But if there's anybody with obesity or hypogonadism itself, even functional, and they have symptoms, and if they've completed their family and they have no other contraindications to testosterone treatment, so then you can definitely treat them with testosterone replacement, provided you're maintaining their levels in the mid-normal range. And it would give them an added benefit of remission probably over time, because they will, their entire metabolism will be better. So you treat them for the reason, and then of course they'll get the added benefits.
Okay, there is one question for Aditi or Saurabha. Should MAFLD be considered one of the comorbidities for indication for bariatric surgery? With one of the criteria for bariatric surgeries, basically.
Yeah, Saurabha, you want to take it, or I? Yeah. Now, this MFLD should be considered. Now, this is the first thing is that if you think about it, it is a relatively new term. Now, let everybody get oriented with it. Like even endocrinologists are getting oriented with it. Once they get oriented with it, and we'll have more data, then how they are progressing, especially MFLD group with some alcohol, whether they are progressing to it, whether we should consider bariatric surgery. Now, but one thing is there that non-NFLD, now all the data has been with NFLD. NFLD has been now the first cause for liver transplant in United States. Now, especially, but liver transplant is not recommended for extreme obesity more than 40 BMI. It is not recommended. They are recommended it to kind of decrease it with bariatric surgery, and then they are supposed to go for the liver transplant. So yes, if we probably are having a lot of MFLD patients who are having progressing to cirrhosis probably, and we need to give them a liver transplant, for them we may need to consider bariatric surgery.
Probably we should do it earlier on, right? After, not after the fibrosis.
After, of course, focusing on diet and lifestyle interventions.
Yeah, that's right. And one more question for Aishwarya, what is the impact of weight loss and lifestyle changes or bariatric surgery on uric acid levels?
Yes, ma'am. So that's a very, very important method to actually, that's one of the first things we should tell our patients about managing hyperuricemia as such. So in the levels that come between say 7 and 13 or 10, like we discussed, the indication for treatment of asymptomatic hyperuricemia, we should always talk to our patient about lifestyle measures, and maintaining the body weight at the level of the ideal body weight would definitely help to bring down the uric acid level. So yes, lifestyle measures in terms of reduction of animal protein intake, reduction of high fructose diets, reduction of alcohol intake. So all these things will definitely sort of help to bring down the uric acid, as well as doing regular exercise or doing something else like bariatric surgery to bring down the weight to the ideal weight. That would definitely help with the uric acid levels. Yes, I didn't mention that in my talk. Yes.
We'll take one last question, I suppose. Should MAFLD be considered? I mean, what is the impact of androgen replacement on lipids? For androgen,
Yes.
what is the impact of androgen on lipid profile.
Right. So treatment with testosterone is also shown to have a positive effect on the lipid profile with reduction in cholesterol levels. So there is a positive effect on even on the cholesterol profile and the entire metabolic profile with testosterone treatment in selected individuals.
Okay, I think it was
And,
very nice talk by all of you. One thing, only very no controversy about is whether hyperuricemia, low testosterone with obesity or with NFLD or MAFLD. Non-controversial thing is lifestyle changes will help, isn't it?
Great. I think that was a really wonderful 2 hours of session. Loved listening to all of the lovely ladies. Thank you so much, Dr. Rajeshwari, for tying together the session so beautifully and leading all of these youngsters. And thanks to Dr. Aishwarya for a brilliant talk on hyperuricemia, Dr. Akshata for talking about low testosterone and obesity, and Dr. Saurabha and Dr. Aditi for beautifully taking us through the concept of MAFLD and what it means. So I think on behalf of the entire team of this session, that is Dr. Shaila Sheikh, Dr. Vaishali Deshmukh, Dr. Belinda and myself, we all sincerely thank you. And thanks Dr. Sarita ma'am and Dr. Rajeshwari for leading us and mentoring us through these sessions. We will love to have you all back tomorrow at 7 p.m. for another 2 interesting sessions, one on bone mineral disorders and the second would be on growth and puberty. So again, we'll take some of the interesting controversies and challenges in those 2 areas tomorrow sharp at 7 p.m.
So congratulations again. All the speakers were brilliant. Aishwarya, Akshata, Aditi, and it's a pleasure to meet Dr. Rajeshwari. Thank you, Gagan. Thank you for inviting me. I really enjoyed all the sessions. I'll be there tomorrow. I'll be there.
Thank you so much and good night, everybody.
Good night.
Good night, everyone.
Good night.
Nice.
See you all tomorrow.
Yes.